Mahesh, just let me know once we are live. I'd just like to request all the participants, if you can please mute your mics. There is a lot of background noise, and it will be difficult for you to listen to all our speakers today.
भेजा मैंने आपको लिंक
मैंने मालूम में ना क्यों ग्रुप पर
yes we call them only when needed.
Mahesh, can you mute everyone and just keep unmute the speaker, please?
डालना का है मेरे से तो कुछ आ ही नहीं रहा है.
तो अभी कितना है? अभी 15 और 20 के बीच.
All right. All right. So I think let's start. Hello, good afternoon, everyone. Welcome again to SRCC Children's Masterclass. And again, today we have three amazing speakers who are part of SRCC Children's Hospital. Once again, I'd just like to tell you that, yes, SRCC Children is fully functional and all our departments are working at full strength and are there to help all of your children and patients need at any time of the day. So let's get on with today's program. So today our first speaker, she's new to the SRCC family. So I'll not only welcome her to the SRCC family, and again, she's the first speaker at our masterclass as well. So I'd like to welcome Dr. Pradnya Gadgil. So she's a pediatric neurologist and has a super specialty, I would say, in training in pediatric epilepsy. So she is quite passionate about this, and she, along with Dr. Saurav, are also a part of the epilepsy clinic, which has been newly kind of envisioned and is going to be starting in full-fledged at SRCC Children's Hospital. So Dr. Pradnya, along the years, has done a lot of work in epilepsy, and she has trained from India and UK as well. She was also a teacher in pediatric medicine and neurology at JJ Hospital and KDH, and now is a part of our SRCC family. She has done a lot of grassroots level work to spread awareness regarding epilepsy and does a lot of rural epilepsy camp. So Dr. Pradnya, I'd like to welcome you to give your talk for today.
So much, Abhi. Really looking forward to be part of the SRCC family. It's always good to be part of a pediatric hospital. That's a very different experience. So without wasting much time, I'll share my screen. The brief that I've been given today is to talk about how to manage complex epilepsy. So I'm going to try and use cases so that, it becomes, all that theory becomes relevant when we see patients in clinic or our patients come to us asking for an opinion as to what's the best way ahead. But before we start with the cases, I would like to give some context as to why think about complex epilepsy, why discuss it, and why devote your energies to, helping children who have complex epilepsy. So let's start with basics. What is complex epilepsy? So epilepsy isn't rare. Or when you look at the population statistics, almost 60 to 70% of patients who have epilepsy across pediatric and adults are easily controllable with 1 or 2 anti-epileptic medications. Some might require 2 to 3 anti-epileptic medications, but 60 to 70% of patients with epilepsy have what we call a simple or a straightforward epilepsy, which is controllable or which is responsive to anti-epileptic medication. However, the remaining 30-40% of patients are the ones who we give a diagnosis as having complex epilepsy.
Participants, chat नहीं chat
Thank you. So what complex epilepsy as a clinical syndrome means is that this is an epilepsy which is difficult to control with our traditional correctly chosen anti-epileptic medications. So it's medically refractory. The seizures are not coming under control despite the patient receiving the right type and the right amount of anti-epileptic medications. What causes it? Virtually any epilepsy can be complex or medically refractory. So it can be acquired brain injury, which is the commonest substrate in a country like ours with a lot of concerns regarding perinatal care that we have. It can be secondary to brain malformations like focal cortical dysplasias, Mri Negative, and so on. But it can also be genetic epilepsy, which is medically refractory. So the etiology doesn't, there are of course some etiologies which would influence the outcomes of epilepsy in it being more complex than others. But as a rule, any etiology can have a subset of epilepsies which are complex or medically refractory. So the problem with the complex or medically refractory epilepsy is that it's a devastating disease by itself. So yes, the patient or the adult will have a lot of seizures which are uncontrolled. They may have some seizures which evolve into a status epilepticus, which we all know can be potentially life-threatening, will require hospital admissions and so on. But apart from the seizures, when the brain is battling complex epilepsy, the other brain also take a hit, especially the cognitive functions. So these are children who have associated developmental delay. Some of them may actually regress because of uncontrolled epilepsy. They typically end up being on a lot of anti-epileptic medications. There are drug-drug interactions, which again add to the problems, especially with tolerance of medications, the side effects with respect to alertness, concentration, cognition, and so on. And all this, uncontrolled seizures, frequent hospital admissions, the cognitive issues that the child has, all this eventually contributes to poor psychosocial integration of that child as well as the family. These are kids who, some of them have normal cognition, but because the seizures are uncontrolled, find it difficult to attend a mainstream school. There are some where they have epileptic encephalopathy, which drives their cognition down. Simple things like attending school, just taking part in day-to-day activities becomes very difficult. And hence, it's so important to recognize kids who have a difficult epilepsy and then escalate their treatment. But what we typically do is give medications. We're all pediatricians, we're all physicians. We love to write medications. That's what comes to us very intuitively. So when faced with a complex epilepsy, okay, 2 drugs have failed, 3 drugs have failed. Why not write more anti-epileptic medications? So there are very elegant studies. These are population studies done in Scotland by the Scottish group anchored by Martin Brodie. What they showed was that if your first 2 anti-epileptic medications have failed in controlling epilepsy, then the chance or the possibility that the 3rd or the 4th anti-epileptic medication will be effective reduces exponentially. So the chance that the 3rd anti-epileptic medication will work reduces to about 10 to 15%. The chance that the 4th will work goes down to less than 4%, and so on. Is this surprising when you understand how these medications work? It's not. It's, to be honest. Even the name tells us, the medications, these drugs are anti-epileptic. They just control the possibility of a patient experiencing a clinical seizure. They're not anti-epileptogenic. They're not actually curing or getting rid of the epilepsy by themselves. They're not changing the epileptic circuits. So, so once we understand this, it's very intuitive that beyond the point, anti-epileptic medications aren't going to be enough to control epilepsies which are very severe in the first place. And these are the patients where we start looking at non-pharmacological or non-anti-epileptic drug treatment. What are they? One is, of course, epilepsy surgery. And there are multiple types of epilepsy surgeries, and we'll look at that. Then there can be dietary treatments. Roshan is here on the panel today. Ketogenic diet is something that's very effective. So if you find that a patient has complex epilepsy, is not surgically remediable for whatever reason, then ketogenic diet is a very promising non-AED treatment option for complex epilepsy. And of course, today we are in a day and age of genomics and pharmacogenomics. So we have targeted anti-epileptic or targeted medication therapies for certain epilepsies. For example, if it's tuberous sclerosis and the patient has epilepsy which is surgically non-remediable, then we look at not anti-epileptic drugs, but mTOR inhibitors, like everolimus or sirolimus, which control the disease. So there are some diseases where the understanding of genetics has helped us to actually offer targeted therapy to these patients. This is where the future lies of patients, and it's much brighter. I can tell you, I can promise you that 20 years ago, if medications didn't work, there really wasn't much that we could offer these patients. But now there are multiple other treatment avenues to patients who suffer from complex epilepsy. So today, given the amount of time I've been allocated, I'm only going to talk about epilepsy surgery. So what is epilepsy surgery? Is it a very new concept? I often get this reaction from friends saying brain surgery for epilepsy. That is almost unheard of for a majority of our population. And they think it's some new advance that has happened, but it's actually not. The first epilepsy surgery was actually done in the late 1800s by a team of a neurosurgeon and an epileptologist, Victor Horsley and Eugene Jackson. Remember, they did this even before EEG was invented. That understanding about what is epilepsy and how to cure it is very, very robust. It's not a new or a recent advance in treatment options. Epilepsy surgery is very special. It's not your standard run-of-the-mill resective neurosurgery where, say, a patient has headaches, the scan shows a space-occupying lesion, it's a tumor, then the neurosurgeon goes in and resects the tumor. Those are resective neurosurgeries. Epilepsy surgery, yes, the neurosurgeon has to go in and resect part of the brain, but it's a functional neurosurgery because what we are targeting is actually the epileptogenic network that has to be resected out to help the patient become seizure-free, if you're talking of curative surgery. So as a concept, it's very different. It's functional surgery. And you need a neurosurgeon and indeed the whole team who understands this concept of a functional neurosurgery. It can be curative if it's a resective surgery, and sometimes it's palliative, which improves quality of life of patients. So again, within epilepsy surgery today, I'm only going to discuss or show you cases of curative epilepsy surgery. But again, let me put some context to it before we go on to the cases. So what are the workings of a curative epilepsy surgery? So like I said, it's a functional neurosurgery. We are targeting the epileptic network in that particular brain. Now remember, we don't see this epileptic network on any scan. No MRI, no PET scan shows us the culprit ictal circuit in the brain. It may not be lesional. There may be a gliosis, there may be a malformation there, but the MRI may be normal and still there could be a very focal epileptic circuit in the brain of that given patient. What makes it challenging for us is that the circuit can be different in each patient. So no two surgeries are alike because what we're targeting is the epileptic network in a given patient. And very, very often, in fact, it's the rule rather than the exception, that the networks are very unique to each individual. So now, given that we need to go and understand the network, and then we can target it, surgical evaluation becomes very, very, very important. I can't think of any other parallel in modern medicine where the tests done before surgery are so crucial to decide whether a patient is a surgical candidate or not. What are these tests? Firstly, the backbone of these tests is what we call a video telemetry or a prolonged video EEG. We admit the patient, there is a camera on, the EEG is going on, and we actually record seizures. We record seizures, the camera captures the clinical semiology of it, the EEG is capturing the epileptic activity of the seizure. Plus, the technicians are doing some dedicated testing during the seizure, which helps us to understand functionally where this epileptic circuit is in a given patient. Then we sometimes do an MRI to see if it's lesional, and very often the lesions coincide with the epileptic network. But we do very special studies in the MRI. We do some epilepsy protocol MRIs, which are very thin cuts, 1 millimeter cuts of the brain. We do things like tractography, where we look at the white matter tracts, because where they are becomes a very important point when we are planning a resection. We can do functional MRIs, testing speech and motor, neuropsychological testing, which again tells us which is the dominant side, is the verbal memory involved, is visual memory involved. Plus, we do interoperative testing, which can be electrocorticography, means the surgeon has opened the brain, and I'll show you examples. We are recording directly from the brain, and sometimes we actually do two-stage surgeries, wherein the video EEG, the MRI, the functional nuclear studies have given us an idea of where the epileptic circuit is, but that needs to be fine-tuned, or the eloquence needs to be tested. Then we actually implant electrodes in the brain using stereotaxy, record from that area, and then fine-tune our understanding further of the epileptic network. And so this pre-surgical evaluation is extremely crucial. Each and every test is not done in each and every patient. Like I said, each patient's epileptic circuit is very different. In some patients, it's very obvious what the epileptic circuit is, and we get away with just a video EEG and an MRI. That's all. But in other patients, the epileptic circuit is complex or elusive, or they're very young patients and aren't giving us a lot of clinical details, there we sometimes need to do extra testing to arrive at a surgical hypothesis. So as you can imagine, it's not only testing, it's a lot of skill sets that are needed as well, apart from the infrastructure. So you need a neuroradiologist who understands this. You need a nuclear medicine specialist. You need psychologists who understand it. And of course, you need a functional neurosurgeon, apart from an epileptologist. So we all come together at the end of each patient undergoing a pre-surgical evaluation. Yes, I as an epileptologist anchor it, but I can do nothing without the rest of the team contributing in their own specialty. Each case gets discussed, and then we see, are we coming up with a hypothesis? Now remember, sometimes the surgical hypothesis may even rule out epilepsy surgery. We might find that we're not coming up with a very robust, a very strong hypothesis which tells us where the circuit is, or sometimes the circuit overlaps the eloquent cortex. So it's not necessary, though we call the testing pre-surgical evaluation, sometimes surgery might actually get ruled out for certain patients following a pre-surgical evaluation. So now with this context, let's look at a few cases. So first case I have is very simple, just to exemplify the point of this functional neurosurgery, resection of an epileptic network. So this was one of my very, very popular patients, a 12-year-old boy. He started having seizures at 4 years of age. He was having daily seizures despite being on 3 anti-epileptic medications. Now his semiology, or the look of the seizure, was that he would have an aura. And the aura was that he would say that डर लग रहा है. He would give a very clear description कि मुझे बहुत डर लगता है, and sometimes that feeling of fear could go on for 1-2 minutes. Outwardly, there would be nothing else that would change in him, but he would keep saying, मुझे डर लग रहा है, मुझे डर लग रहा है. Then sometimes a seizure would get over just with that feeling, but sometimes he would go blank. He couldn't talk, what we call an absence-like spell or a dialeptic seizure. He would have some hand automatisms, and then he would snap out of it. Rarely, this event would progress to a convulsive, a secondary generalized clonic seizure. But he was having daily seizures despite being on anti-epileptic medications. His IQ was okay. He was low average. He was attending school. He was left-handed. Nothing in the birth history or the family history which would give us a pointer to what was the cause of this epilepsy. He had normal milestones. So he had an MRI done outside. He came with the MRI report as they do. And the MRI said he has left mesial temporal sclerosis. And the previous EEG also showed left temporal shunt phase. Now, this sounds okay. He has an MTS. The MRI and the EEG are showing abnormality in the same place. However, what's not matching is the look of the seizure or the clinical semiology. Aura of fear, we know, doesn't come from the mesial temporal area. Mesial temporal area is the area of the hippocampus, which looks after memory. That doesn't really give rise to fear as a starting point of a seizure. So, this didn't quite fit in. So, though there was an abnormality on the MRI, the clinical description of the seizure did not indicate that the seizure is starting in the MRI abnormality. So, there is discordance. So basically the clinical syndrome of this patient was that he has a medically refractory focal epilepsy. That's very clear. Medically refractory, it's focal with an aura of fear. Possibly temporal, but we needed to confirm that. So this is a patient who should ideally get admitted for what we call a pre-surgical evaluation. So he got admitted with a video. We got very easily recorded 5 seizures over just 2 days. And the seizures did lateralize and localize to the left anterior temporal, but not to the mesial temporal. So, in that region, but not exactly where the lesion is. This is just a example of the EEG where you can see the electrical activity on the left anterior temporal electrodes. The clinical neuropsych was done, which showed that his verbal memory was slightly worse than the visual memory. So that suggested that this was possibly an element of dominance. But it still wasn't helping us come with a concordant picture. So then we reviewed the MRI. So this is the MRI. You can see the arrow points to the MTS, the mesial temporal sclerosis, which is pretty obvious on the left side. But what else is there? What else is there is he has can you see this region called the amygdala? If you all remember neuroanatomy, amygdala is the area of our brain which controls fear. So if you look at the amygdala on the left side, which I'm pointing out right now, and the one on the right side, there's a big difference. The one on the left is quite large, it's globular. This is actually a dysplastic amygdala. There is a cortical dysplasia in the left amygdala. So the seizure was actually starting here in the amygdala, which is why he would get the aura of fear, and then it would possibly spread. He had so many seizures over years that actually caused a secondary mesial temporal sclerosis. So the MTS, the sclerosis here that you can see the hippocampus, the white area, again compared to the right, you will see that this is smaller. It's looking whiter, tells you that this is gliosed. So the seizures over years coming from the amygdala, sometimes possibly even status, has resulted in the MTS. This is a red herring. This is not the actual cause of his epilepsy. But the amygdala dysplasia now nicely fits in. So we did any further tests apart from our video EEG and reviewing the MRI that was already done. So we did a left anterior temporal lobectomy with amygdalohippocampectomy, and these are the post-operative pictures. You can see that this is the hippocampectomy has been done, and the amygdala has been removed as well. And this child, like I said, this was one of my very first patients. He's seizure free for 8 years. His IQ scores are intact. He's doing well, completely cured of an epilepsy that was complex and so difficult to control with anti-epileptic medications. So this was a simple, very straightforward case. One video EEG, MRI, and a good clinical history gives you a very concordant epileptic circuit and treated. But are all cases so straightforward? Not really. There are certain substrates which prove very challenging in epileptic. What are these? These are if the lesion or the network, the epileptic network involves eloquent cortex. For example, if it's on the motor region or the visual eloquent cortex, then removing it will give rise to deficit. These decisions are the ones which are challenging. Then very often we have patients who have multiple lesions in the brain. So which lesion is epileptogenic? Where are the seizures coming from? Becomes a problem. If you remove one lesion, Will seizures continue or start from the other lesions? So some difficult questions to be answered there. And of course, MRI negative, where the MRI is completely clean, does not show any area of abnormality, but you know that the circuit is in one area of the brain and need to come up with a hypothesis despite the MRI being normal. So just going to show you one case of each. So let's start off with a case involving the eloquent cortex. So this was a 12-year-old boy, right-handed. He started having seizures at 6 years of age. He would have daily what we used to call complex partial seizures. Tried 4 anti-epileptics, good anti-epileptics, correct choice of anti-epileptics, but would continue to have daily seizures. The semiology was that he would just go quiet. He wouldn't call out like the earlier chap, he would just go quiet. Thereafter, he would say that I can see red and then I can't see anything. So he's giving history of a visual aura. So he sees the visual goes red, then he goes blind, can't see anything. Sometimes he has very formed visual hallucinations that he could say, I'm seeing somebody. In Gujarati, I remember in the video, he would say, Manas dikhai che, Manas dikhai che. He would see somebody. Then his head and eyes would turn to the left, and the seizure would terminate. So very brief but daily seizures in which the aura or the starting point of the seizure was that of was visual, either ill-formed, like just going blind, seeing red, or sometimes very well-formed visual hallucinations of seeing a person who's not there. He had normal birth history, normal family history, normal milestones, so really nothing telling us what would have giving a pointer towards etiology. He has an element of learning difficulties. The clinical syndrome here that we're dealing with is a medically refractory focal epilepsy with occipital features. So again, this is a patient who should go up for a pre-surgical evaluation. So we did a video EEG. We recorded 4 seizures in 4 days. The seizures lateralized and localized to the right posterior quadrant. If you can see that they only localized to the right posterior quadrant, but where in the right posterior quadrant are the seizures coming from? The video EEG didn't give us any further information which could help us fine-tune. As they do again, he came with an MRI, we looked at it. And as you can see here, here's a large porencephalic cyst at the corner of his right, lateral horn of the right ventricle. And there's a sliver, I don't know if it's projecting well, there's a sliver of cortex here, which is the calcarine, which is your eloquent visual cortex, which is where probably the seizures are coming from, because he's getting that formed visual aura of seeing a person at the onset of a seizure. So given that he already had a large porencephalic cyst and we're dealing with the visual cortex here, we did his visual fields. He already had a left superior quadrantopia. He had 1/4 the left superior quadrant field defect already in existence. But the problem was, yes, the clinical semiology, the video EEG, the MRI are all very concordant. The seizures are coming from this tiny sliver of calcarine cortex on the right. But if we resect this, remember, the porencephalic cyst is not giving rise to seizures. This is just a fluid-filled cyst. It's the cortex around it which is giving rise to seizures. So if the surgeon goes and resects this, then there's a risk that this child would have a hemianopia because we are resecting the eloquent cortex on the right. So we went ahead and did some additional functional testing. We did a functional MRI and tractography. You can see the functional MRI on your right here. The red area, this is functional MRI for vision. The red highlighted area is what lights up when the child is given visual tasks. So we found that all the vision is only lighting up on the left side. There was no vision really lighting up on the right side. Plus, when we did tractography, you can see that on the right side, the tracts are start at the back of the optic nerve, and they're completely intact all the way back up to the occipital cortex. But on the right side, okay, the tractography, the MRI images are flipped. So on the right side, the tracts are stopping short and actually do not carry on to the sliver of calcarine that's left behind. So these two studies showed us that the sliver of calcarine that's left behind possibly isn't contributing a lot to his vision. So with this information, we did a tailored excision of that right porencephalic cyst and went right up to the occipital pole and the midline. He's been seizure-free ever since. And he post-operatively, we did visual field testing, perimetry again. He had the pre-existing left superior quadrantopia, and that did not worsen. We did not give him any additional visual field loss. So again, despite the seizures coming from what looked like Eloquent cortex, we were able to give him seizure freedom with some very basic testing done, because we were able to come up with a very, very robust surgical hypothesis. Now to the next challenging substrate, which is multilesional, and this is actually much more common substrate that we see in India. A 14-year-old girl, right-handed. She was an ex-NICU graduate. She was full term, but she had seizures on day 1. She spent up 9-10 days in NICU. The diagnosis at that time was HI grade 2, grade 3. She had global developmental delay, but nothing focal. So she had delayed walking, delayed speech. She was going to a mainstream school, but really was failing. She had reached 9th standard, but had significant issues with learning. But otherwise, had no spasticity, no dystonia, nothing focal motor. Would go about her day-to-day work like any other child, but of course had significant academic issues. So she had seizures which were weekly, and they would happen in clusters. And every time she would get a cluster, she would go off school. So the semiology, she would say that something is happening. Given her cognition or the aura itself was very non-specific, she couldn't elaborate anything further. All she would tell us was, just before the seizure starts, she knows that it's coming on, something happens to her. But what that something is, she couldn't elaborate on it. Now this becomes a problem, because if you see like the first 2 cases, if the child tells us fear, we immediately are looking at the amygdala or other areas of the brain that will control fear. If a child says visual hallucinations, they are immediately looking at the visual cortex, which so it helps us localizing. In this case, we knew that the onset is focal because the child experiences a focal sensation and aura, but where, right, left, frontal, parietal, without details, we didn't know where to localize it for. So the semiology was that she would report something's happening, then her head would turn to the left, her face would pull to the left, and occasionally this would generalize. So let's look at the seizure. So this is a video from the video EG while we are doing our SPECT. Avi, can you see the video?
Right side, patient teaching.
And of course, the EEG tells me that the seizure is starting from this is the video EEG. So the video goes on, and you can see that there is abnormal activity starting in the right posterior quadrant, right temporoparietal, and then it progresses and becomes secondary generalized. So again, the clinical syndrome with this patient is medically refractory epilepsy with definite focal features. However, now these were the seizures that were happening weekly. We of course did a video EEG much later, but let me just tell you the dilemma in this case. The MRI in this girl had 3 lesions. As you can see, she had bilateral periventricular leukomalacia, right as well as left. The arrows hopefully show that to you on flare. And plus, she had a right-sided mesial temporal sclerosis. So she had 3 lesions which could possibly be epileptogenic. Now, she already had pre-surgical evaluation in some other hospital. They had done a video EEG, an MRI, and a PET scan, and they weren't able to come up with a surgical hypothesis. And then, quite rightly, they said, we cannot offer you surgery. So the dilemma was, do I revisit the whole pre-surgical evaluation? In our country, they're always, it's a cost to the patient, and they're always trying to see, am I going to add any value to this patient's clinical journey by doing any further testing? We decided to go ahead with it. Why? Because the seizure semiology was so stereotypical. Every single time she would have a seizure, is that same thing that would happen, and there was an indication of a very strong focality. So our pre-surgical evaluation showed, the video EEG showed very frequent right posterior temporal intellectual discharges. We recorded 10 clinical and 20 subclinical seizures in 48 hours. The family didn't even know of the 2/3 of the seizures that were happening. So about 30 seizures in 2 days. The more the number of seizures, that's very, very robust information. So these seizures localized to the right, but definitely lateralized to the right hemisphere. We did a little SPECT. Given that this is multi-lesional, this is a patient where we would do other testing apart from video and MRI. And of course, we did function in Mri and Tactography. And we used that was done.
एक मिनिट हे बघ ते माझं ती बॅग दे ना या पिशवीच्या पाठची बॅग हा का
ते काय झालं ते आपण कलर करायला घेतला ते त्यांना नाही कळलं आपण आता अजून मला तेवढं डोक्यात आलं नाही म्हटलं ते काम पण होत नव्हतं म्हटलं कशातच गेले असते राहायला.
Dr. Suresh Raut, can you?
Dr. Raut, Dr. Suresh Raut, could you please mute yourself?
So we compared the to the interictal SPECT, and we found that is lighting up as compared to the interictal SPECT. This is the region lighting up. You can see a lot of red here. Which is the ictal SPECT, and this is the interictal SPECT where it's all quiet and green. So this quiet, slightly low metabolic area becomes hyper metabolic during a phase, which is another surrogate evidence just that the is coming from the right area. That the tracks were gliosis, and the tracks were right there, very close to the area of gliosis. So this gyrus is the riotic gyrus, and just one central sulcus in between, and the motor eloquent cortex is just anterior to what is the anterior margin of our area. When you have such a complex substrate, the 3 lesions we narrowed it down to 1 lesion. So the current seizures were all coming from that 1 lesion, but that lesion is also very close to the motor area. So that makes the surgical resection that much more demanding and challenging. Also remember, these are injured brains. Where we imagine eloquence to be, that may not be the area of eloquence. So you have to always take into account these possibilities. So this is an example of our notes of our epilepsy surgery discussion. This patient got discussed 3 times. So a lot of work happens in the background for these patients. The surgical evaluation is just so the discussion was that yes, we had a hypothesis, but given that the motor is so close and the fact that she does not have any current motor deficits, to try to do an awake surgery. But this was a girl who was very uncooperative. She got admitted. She gave up as a protest as to why she was admitted to hospital. So the chance that she would cooperate for awake surgery was quite unlikely. So we decided to go ahead with a resective surgery, but to supplement testing of the eloquent cortex, we decided to do electrocorticography and cortical motor mapping intraoperatively. So what is cortical motor mapping? So this is an intraoperative picture. The craniotomy is done. That's the cortical stimulator.
What?
So we are stimulating.
Yeah.
That's the intraoperative monitoring tool. That's the patient's hand. As we stimulate, you can see that the hand is becoming distorted. So the area which was being stimulated is actually the motor cortex.
1 minute.
Okay.
Ready?
So this is the kind of intraoperative monitoring that we can do with the patient sedated. Now, if she was awake, we would have actually stimulated and gotten her to do active motor activity and see whether we are actually stopping, inducing a paralysis. Also, while resection, these patients can keep moving their particular limb, which helps us to understand the workings of the So using this intraoperative testing, we did a very tailored wedge-shaped dissection of the gliosis staying behind the central sulci. She woke up with a dense hemiparesis on the first post-operative day. However, this improved. We did tactography post-operatively, and we saw that we actually hadn't injured any of the tracts. There was so she was able to walk by day 7, and now there is absolutely no weakness in the lower limb. However, the fine on the left hand is still poor. She is right-handed, so this doesn't really affect her quality of life. So she's seizure-free. We operated in 2016. Now about 6 years, she's seizure-free. Despite having 2 residual lesions in the MRI, all 3 empirical discharge. With that, moving to Macronutrients. This is one of the most challenging substrates. 20-year-old right-handed girl. Seizure started in 2018. My Dahanu and she came to her. She started having seizures very recently, 2018. Early seizures despite the anti-epileptic medications. She gave a very beautiful, very elaborate history of what she experienced during the seizure. She would say that the whole right upper limb was heavy. That is how the seizure starts. माझा उजवा हात जड होतो. The challenge with जड, colloquial Marathi जड होतो is that can mean weakness, which could mean motor. That can mean an unusual sensation, which could mean sensory and secondary somatosensory areas. It could mean dystonia kind of a feeling, which could mean insula on the estimate. But it's a right hand, so we know that it's coming from the left hemisphere. And that aura sort of gives us some 3, 4, 5 areas in the right front, in the left frontal lobe to look at. Use awareness, then it should have a head and body turn to the right, and then should fall down, and then should have become a motor clonic seizure on the right. These were brief events. She had no post-treatment weakness, but she was off school because the seizures were daily, and then in one seizure she fell down and had a right elbow fracture. So this was cognitively completely normal, wasn't active. And so she had a normal neurological examination. So the clinical syndrome here is a medically refractory epilepsy, left with impaired awareness, very sensory query motor onset. So all this information we've managed to get just from the clinical. All of you are very, there was a pre-surgical evaluation. The first stage pre-surgical evaluation did confirm. The video you said yes, the seizures are coming from the left frontal, which tied in very nicely with the clinical synology. MRI brain was normal, so we went ahead and did further imaging studies. We did a PET brain, which showed a subtle hypoperfusion, not enough for us to come up with a surgical hypothesis. We did a SPECT, we processed it using system, and that again told us that yes, somewhere there is left prefrontal, but where exactly? Now, given that this was an Mri negative epilepsy, we also did genetics, because sometimes you can have focal genetic epilepsies, which will not be surgically remediable. So we did genetics. We all have heard of autoimmune epilepsies, which are present in focal features. So we did the antibodies, NMDA, but this was all negative. So in our meeting, we discussed that yes, this is a child with negative refractory epilepsy. It's left frontal, no doubt about it. But she's right-handed, so it's possibly the dominant lobe for her. But where in the left frontal, no clues from the imaging. All we have is an electrical hypothesis. So the possibilities were: is this a prefrontal onset which is going to SMA? And is it a parietal onset, starting in the sensory, the S1, and traveling across the central sulcus anteriorly? If it's prefrontal, where in the prefrontal? Is it frontopolar? Is it superior frontal gyrus? Is it anterior cingulate? Is it insula? So where in that large prefrontal area? So this is a patient who benefits from what we call a two-stage evaluation. So we planned an SEG implantation, which are electrodes, which are practically in that prefrontal area. Now we've narrowed down to the left prefrontal and implant the electrodes. So because when we are in a large area and we fine-tuning the surgical hypothesis, it really gives us a lot of information for surgical planning. Not just epileptogenesis, but eloquence can also get tested. And sometimes it might, whatever our first stage pre-surgical evaluation hypothesis that we've come up with, that might even get proven wrong sometimes. So it's a very, very useful thing if we have, if all our questions are not getting answered with one stage evaluation. Implantation, these are the electrodes. So these are the 3 insular electrodes. These are 3 cingulate electrodes, and these are the frontal electrodes, and the polar mid-frontal. This is SMA, this is motor, and this is post-central reaching up to the pituitary. So this is the data that we get from a stereo EEG. This is the interictal data, because these are 11 electrodes, which has about 6 to 8 contacts. Each contact is recording. So this is the humongous amount of data, lot of spinning lines that we get from our stereo EEG. And of course, we are able to filter it, and we saw, in fact, in the OT when we were checking the electrodes, we saw that part of a middle frontal gyrus is continuously spiking. So we knew that we had gotten our electrode right where the possible abnormality was. I'm just going to show you the EEG. So this is where can you see the EEG? So you can see the EEG. So she's sitting, she has those 11 electrodes implanted. We are recording. This is the amount of data that we are getting from the seizure. A lot of testing happening in during the seizure as well. So this testing that happens during the seizure, very often I get asked a question by parents and sometimes doctors too. वीडियो बना के भेजते हैं, उससे होगा क्या? उससे नहीं होता है, because we do need to objectively test what's happening in the clinical seizure. So we recorded and we found that there are the MCG electrode, contact 5 is the one which is giving rise to maximum interictal discharges and the seizure. And this is a neural navigation system where we just zoom in, these are electrode contacts, and this is the area which was giving rise to seizures continuously. We also stimulated these contacts and elicited electrical seizures. So we had a very clear hypothesis as to where the seizures are coming from. Though the MRI was completely normal, there is really nothing that we can point out here in the MRI. So we did a neuronavigation guided surgery using electroplethysmography and depth electrode in the middle frontal gyrus, which was what we had identified. Remember, we cannot do this without navigation, because when the surgeon opens up, the brain is looking all normal. There's nothing that tells him where to go. So this is our interoperative testing. These are the spikes that you can see pre-resection in the depth electrode, and then post-resection, the corticography is completely clean. So post-operatively, she, remember now, this is the dominant hemisphere. Post-operatively, she developed an element of aphasia, which fully improved in 2 weeks. This is the tailored resection that we've done in an area of the brain which looked normal on MRI and other imaging. Because aphasia, we did tactography post-operatively. But had just restricted gyrus. So she's completely seizure-free ever since, and we operated her during the pandemic, and now she's off her anti-epileptics. So I hope these cases have just demonstrated, just given you a flavor of how patients with different types of complex epilepsy could be helped. So there's a substrate within patients who have complex epilepsy, which are surgically remediable. However, how do you identify these patients? So the ones who have medically refractory epilepsy and have complex epilepsy should get evaluated, should get referred on. So you can give them a chance to see, are these patients, can we cure them of their epilepsy, not just control them. In fact, it's an ILA and Ayan recommendation that every patient with surgically remediable epilepsy should be offered at the failure of the second anti-epileptic medication. But the surgically remediable, yes or no, identifying a patient with surgically remediable epilepsy is the critical part in the whole clinical journey of these patients. Thank you.
Thank you, Dr. Pradnya. That was a wonderful talk. As of now, I'm not seeing any questions in the chat box, but since Saurav is here and he's a part of the epilepsy clinic with you, is there something, Saurav, that you would like to ask, or some topic that you would like to raise, so that till we wait for a few questions from the audience?
Yeah, no, I think this was in the limited time that was given to Pradnya. I think she has really elaborated everything and discussed everything very, very well. In fact, all the 5 cases were really very illustrative of the points that she was trying to make. And I think I would also reiterate the same message that she tried to give everyone, that all surgical remediable epilepsy cases should be referred to an epilepsy service, a center where there's a team in place which is working together and evaluating patients, and the patient should be given the benefit of the whole epilepsy service program. Yes, like she said, there are quite a few tools which are used in making the whole pre-surgical evaluation as well as the surgery more helpful and more tailored. Yeah, those things only add to the success of the epilepsy surgery.
Thanks, Saurabh. So I know Pradnya has spoken a lot and shared such wonderful cases. So you are the surgical side of the epilepsy clinic. So from your side, is there a take-home message that you would like to add to the medical side of the epilepsy clinic, which Pradnya has cleared so nicely?
So the take-home message is that, again, the first thing is the patient needs to be referred at the right time. I think as a surgeon, not only as a surgeon, I think as an epilepsy service and as a team, it is very, very critical that patients receive their surgical intervention at the right age, especially with pediatric population. The advantage that children have over adults is the brain plasticity. So, brain plasticity roughly is the flexibility that a pediatric brain has. After an age of around 7 to 9, the brain becomes, maybe in simpler words, a little more rigid. And so therefore, if there is a surgical hypothesis and if there is something that can be remedied by surgery and we delay it unnecessarily only because the patient was not referred early on, we are taking away that benefit from that child to recover from any damage whatsoever that the epilepsy will cause or the surgery might cause. So I think early referral is the key.
Great message, Saurav. So there's one question for Pradnya. They've asked, what is the role of steroids, IVIG in refractory epilepsy?
The etiology is what decides whether these immunomodulatory treatments would help in refractory epilepsy. So we all know that there are certain epileptic encephalopathies where steroids are the first choice. West syndrome, patients in the first year of life, post perinatal insult, sometimes can start having what we call infantile spasms. EEG shows it's arrhythmia. We diagnose them as having West syndrome. Steroids are the first line. It's not anti-epileptics, it's steroids which is the first line treatment. But then in later life, when you are faced with refractory epilepsy, if the epilepsy is immune-mediated, like sometimes these are autoimmune epilepsies, wherein steroids and IVIG are again the first line treatment option. It's not anti-epileptic, it's symptomatic. So if we recognize an autoimmune epilepsy and we need to make an effort to do that, then steroids and IVIG play a very important role. There are some other epileptic encephalopathies, Lennox-Gastaut syndrome, LKS, Landau-Kleffner syndrome, wherein we give steroids and we do have limited success sometimes. IVIG doesn't so much help in the other epileptic encephalopathies at a later age. So IVIG has a much limited role with respect to epilepsies. Steroids, yes, very important in the early epileptic encephalopathies and even in later life.
Thank you, Pradnya. So I think we are perfectly on time and keeping in with staying on time for the masterclass as always. Thank you so much for your great talk. And so if there are any questions at any point, please put it down in the chat box and we will try to get Dr. Pradnya to answer it to you at any point in time if it's possible. So I'd just like to introduce Dr. Saurav, who's our new neurosurgeon, and Dr. Aoyon is already waiting. So if you'd like to introduce him, and then we'll get on to the next talk.
Thank you so much. Thank you, Avi. So welcome one and all. I think it has been an overwhelming response to this masterclass, and that's very encouraging in itself. Without wasting any further time, I'd like to welcome and introduce Dr. Ayan Sengupta. He's a pediatric intensive care consultant with NHSRCC Children's Hospital. He has experience in providing specialized care to critically ill children. He is experienced in pre- and post-operative management of bone marrow, liver, and renal transplant cases as well. Dr. Ayan is an accredited teacher for the IAP PICC and the College of Pediatric Critical Care Diploma and Fellowship courses in Pediatric Critical Care. And he's a guide for postgraduate dissertations for DNB Pediatrics. He has conducted various courses like the Neonatal Advanced Life Support, Pediatric Advanced Life Support, and Advanced course in Pediatric Critical Care. And he's an instructor for the IAP Advanced Life Support and Basic Life Support courses. So Dr. Ayan, welcome, and I'll let you proceed with your presentation. Thank you so much.
So I'll share my screen.
Yeah, please do.
Yeah. So thank you, Saurav, for the introduction, and thanks to the organizers of the masterclass for giving me this opportunity to be here today. The topic that we thought we'll discuss was office management of pediatric emergencies. But as the introduction about me says, I am an intensive care person, so I couldn't but get some intensive care stuff into the picture in this presentation also. So we have just increased the scope of the topic a bit. Let's see how we have done that. So what we'll do is we'll start off with assessment of a sick child, because if you are dealing with an emergency, you have to first pick up the emergency. And I'm sure it's just going to be a sort of a revision for all the participants in this forum today, because all of us have been there, done that, assessing a sick child and how to go about doing it, but we'll just recapitulate it once. during the course of this session. Once we've done that, we'll talk of common emergencies encountered in the office practice, the general and specific measures that are aimed at stabilizing a sick child. And post that, also, we'll talk a little bit about how to transport a sick child. Because if you have encountered a sick child in your office, in your OPD, and you have done the initial job of stabilizing the child, you may need to send the child to a hospital, to an ICU, which may be able to take over. And the good work that you have done in stabilizing and resuscitating may be continued, and the child may be stabilized further. So this is basically going to be the scope of today's discussion. We start off with assessment of a sick child. So why do we need to do this assessment part very properly? Because, this is the most important thing. Children, when they are sick, the problem can be either respiratory or circulatory more commonly. Now, if you have a respiratory issue, it starts off with mostly a respiratory distress, progresses to respiratory failure, and if no intervention is provided to the child in these two steps, it may proceed to a cardiorespiratory failure and a cardiac arrest. A circulatory compromise most probably will present as a shock. And again, if this shock is not picked up and intervened upon, we will end up with a cardiac arrest. Same with an arrhythmia, but more commonly shock. Also, please remember that in the pediatric setup, cardiac arrest is often secondary to a respiratory issue. It is hypoxia, bradycardia arrest. A direct cardiac arrest because of a cardiac situation is not that common in the pediatric population. It is often hypoxia, bradycardia arrest. So if we can identify a child in respiratory distress or impending respiratory failure or a child in shock and intervene at that step, we may prevent a cardiac arrest from happening. And that is what we all want to do. We do not want the child to proceed to cardiac arrest and then undergo CPR, and then things go all haywire from there. So hence the importance of picking up the signs and symptoms and clinical features which tell us that this child is sick and this child has a problem, and we intervene when we can salvage the child safely. So going about it is very simple. The PALS algorithm, I think all of us have gone through it, is the best way of doing it. It is structured, it is comprehensive, and it tells us what to do at which step. It starts off with the initial impression, progresses to the primary assessment, which is the ABCDE part, the secondary assessment, and finally the diagnostic test. We will limit ourselves to the initial impression and the primary assessment mostly today in this brief interaction that we have. So the initial assessment or impression primarily goes by the mnemonic CBC. So what happens is a child has come into your OPD or into your clinic. Now, even before you have thoroughly examined the child, you have just set your eyes on the child and you can see and hear a few things. This can be done in a few seconds. You see whether this child is alert, whether this child is drowsy, whether this child is unresponsive. Look at the color of the child. Is the child looking ashen, cyanosed, or pale or mottled? And is the child breathing up well? Are there any abnormal sounds that you are hearing in this child when the child is walking into your OPD? Very brief, within a matter of seconds, you should be able to do the CBC part, the consciousness, breathing, and color part, and pick up any problem at that point of time. So consciousness, alert, irritable, and unresponsive. Breathing, increased work of breathing, abnormal sounds you can hear, like you can hear a stridor or a wheeze or a grunt, even without a step, even without auscultating the child. The color of the child, any abnormal color, if the child is pale, mottled, flushed, you can pick up and you know there's something wrong with this kid right away. Proceeding further, if the CBC is okay, you go to the ABCDE part, which is the primary assessment. A for airway, B for breathing, C for circulation, D for disability, and E for exposure. Now the details about them briefly. So in the airway, what we need to know is the airway patent and open so that the airflow into the lungs and out of the lungs is unhindered. So this can be picked up by abnormal sounds that you can hear when the child is breathing, or looking at the child. If the child is in distress, you can pick these things up. Now, this airway can be clear. That means it is open and there are no issues with the airway whatsoever. It can be maintainable, meaning there's something wrong with the airway which can be fixed with simple steps or simple maneuvers. Not maintainable means there's something grossly wrong and something more advanced need to be done. What are they? We will look at them. Now, we go ahead with the ABCDE. B for breathing. We look at the respiratory rate. We look at the respiratory effort. We look at again at the chest wall expansion and air movement. We auscultate the child and look at the airway sounds here. and we do the pulse ox and check the saturation of the child. Circulation deals with heart rate and rhythm, the peripheral and central pulses, the capillary refill time, the skin temperature and color. We look at the blood pressure. We also look at some surrogate markers of circulation, which are the urine output and the sensorium. Because if the urine output is dropping, it means that the circulation is suffering. The kidney is not getting adequately perfused. If the sensorium is dropping, it means that the brain is not getting adequately perfused, and hence hypoxia may be setting in the brain. So these are surrogate markers which tell us that the circulation is not optimal. The next is disability, which is the D part of it. It is a quick evaluation of the neurological functions to see whether the child is neurologically intact. Look at the consciousness, muscle tone, pupil responses. We know the AVPU and the GCS scoring systems. So this is how we go about doing that. In exposure, we look at the temperature, we look at the blood sugar levels, we look at the skin and other things to look at any bleeding or any trauma or some such stuff. So this is basically in brief what the ABCDE entails and what we need to look into in all these parameters. So as we discussed before, simple maneuvers, what are they? Head tilt, chin lift, jaw thrust. But most important is, the child will try to assume a position which gives him maximum benefit. So if the child is otherwise not that sick, allow him to assume a position of comfort for himself. Otherwise, you can do a head tilt, chin lift, a jaw thrust. If there's a cervical spine problem you are anticipating, oropharyngeal, nasopharyngeal tubes will be used to keep the airway open, a Heimlich or back slaps chest thrust if you are suspecting a foreign body. Advanced maneuvers can be ET, LMA, laryngo, bronchoscopy, and stuff like that. Illustration: jaw thrust, head tilt, chin lift, back slaps, chest thrusts, oropharyngeal tubes, nasopharyngeal tubes, ET tubes. I'm sure we're all familiar with this stuff, but just reinforcement of it. Now, respiratory rate, we need to understand what's important. Respiratory issue will most commonly present with an increased respiratory rate. That is one of the first signs of developing respiratory distress. And once it progresses further and in a situation where there's an impending respiratory failure because the distress has not been identified or acted upon, that is where you will end up with a decrease in respiratory rate of bradypnea, which is a much more ominous sign, which is a late sign. So we should not let the child progress to that end, And if the child is presented in that stage, that means it is really a serious state of affairs at that point of time. Any rate more than 60 or less than 10, irrespective of the age of the child, should be a matter of concern and should raise a red flag for us. Respiratory efforts, look for nasal flaring, look for retractions. Now, seesaw respirations and head nodding, they are also signs of respiratory distress, but more often we will see them if there's a neuromuscular insufficiency also. But all these parameters help us pick up a child in respiratory distress. Pulse oximetry, very important. All our clinics should be equipped with pulse oxes, especially now with COVID and stuff. So a saturation of more than 94 is optimal, indicates adequate oxygenation. But a saturation of less than 94 is an indication to start oxygen. A saturation of less than 90, if the child is receiving supplemental oxygen, means that additional interventions are required for this kid. And we should be, again, it should be a red flag for all of us. So these are the blood pressure numbers. The problem with the pediatric population is that one size doesn't fit all, so one number doesn't fit all. So for different age groups, we will have different numbers that we have to keep in mind, unlike in the adult population where one number suffices. So the numbers that are displayed here are basically the fifth centile. Fifth centile for systolic blood pressure for that age. Below that, the child is in serious trouble, it's hypotension. So for term neonates, 60 is the cutoff. For infants, 70 is the cutoff. For the age group of 1 to 10, we have a formula. That is 70 plus age into 2. So for example, if you have an 8-year-old child, so 70 plus age into 2 will be 8 into 2, 16 plus 70, so 86. So a systolic that you need to ensure is maintained is 66, 86 and above. And for children more than 10 years, 90 is the cutoff. You need to ensure that the systolic is more than 90. Please remember that these are just the fifth centiles. They are not optimal blood pressures, but they are the fifth centiles. They are big, big red flags that we need to remember. So respiratory distress and respiratory failure, how to differentiate between them? Respiratory distress will be set up with tachypnea, tachycardia, increased respiratory efforts, with or without possible abnormal sounds. Respiratory failure is a more advanced stage. No intervention done for the respiratory distress. Child is struggling to breathe, child is compensating, and finally the body gives up. You tire out, you get fatigued, and that is when the body gives up, and you are now in bradypnea, apnea, bradycardia, cyanosis. Your sensorium is taking a hit because your oxygenation to the brain has taken a hit, and you may go into a stupor and coma. So respiratory distress is what it always starts off with, but it progresses to respiratory failure, and that is ominous. From the circulatory perspective, you have two parts: compensated shock and hypotensive shock. So again, the starting point is a compensated shock, when the body is struggling to ensure that there's adequate cardiac output, adequate delivery of oxygen and nutrients and substrates to the tissues. So again, there'll be tachycardia. The peripheries will be cold. You will have a prolonged CRT. You will have weak peripheral pulses, weak central pulses. The child may go into oliguria. If again, no intervention is done at this stage, we go into a stage where the blood pressure drops. So please remember, blood pressure is not the criteria to diagnose or identify shock. You may have a child with a normal blood pressure, but still in shock. So please do not use blood pressure to identify shock. Once you have dropped your blood pressure, you are in hypotensive shock. And the most important point that I want to reinforce over here is, from compensated shock to hypotensive shock may be several hours, but from hypotensive shock to an arrest, maybe a minute, a few minutes. So if you are in hypotensive shock, red flag, urgent intervention immediately at that point of time, cannot waste time. So a recapitulation of what we've done so far: the respiratory part, we have respiratory distress, respiratory failure, and the sites of problem can be upper airway, lower airway, lung parenchyma, and neurological issues. The circulatory insufficiency may be compensated shock and hypotensive shock. Types of shock may be hypovolemic, distributive, cardiogenic, and obstructive. It is important to remember because the initial interventions, your stabilization interventions will be based on what kind of shock you these are the life-threatening things. Again, it's a recapitulation. I'll skip this. Now, this is important. Whatever we do at any point of time, it has to be a cycle that we need to follow. We evaluate the child, we identify the problem, and then we intervene. But we cannot do an intervention and just walk away from the child, because we need to know the effect of our intervention. We have done something for the child. What has happened after that? Did the child benefit from the intervention that we did? Or did the child not benefit, or the child has worsened since that intervention? So these are the things we need to look into, identify. So this cycle of evaluation, identification, and intervention has to be performed till the child is stable and no further immediate intervention is required. So suppose you have a child who's coming breathing hard, breathing fast, a bit of low saturation, and you have given the child oxygen, repositioned the head and neck, suctioned the child out. What happened after that? Did the oxygen improve? Oxygenation improve? Did the child start breathing better now? We need to answer that question. Suppose the child is in shock and you have identified that and given a fluid bolus. What happened after that fluid bolus? Did the heart rate drop? Did the peripheries become a bit warmer? Are the pulses a bit better? Yes or no? If no, does the child need another bolus after this? So again, re-evaluation and need to look into it continuously in a cycle. A child has come with seizures. You have given a midazolam stat on the bedside. What happened after that? Seizure subsided, or is the child still seizing? Does the child need more intervention? Child comes with vomiting. You give an antiemetic. Did it help? Is the child still vomiting? Is the child still not able to retain orally? Because they will have an impact on what you do next. So please remember, whatever evaluation, identification, and intervention you have done, it needs to be a continuous process. You cannot do an intervention and walk away from the child, because the child may need further evaluation always. So this is the last part of this part of the talk, secondary assessment, which deals with a focused physical examination and a focused history taking. Sample is the mnemonic: signs and symptoms, allergies, medications, past medical history, last meal, and the events leading to what has happened now. Promptly take these histories, because it may be important to help us do the next step of interventions. Now we come to the topic after this brief deviation from the topic: common causes of respiratory issues that we encounter in our office practice. So again, we'll divide it the way I've done it before: upper airway problems, lower airway problems, and lung parenchyma issues. Upper airway issues can be an angioneuritic edema, enlarged tonsils, adenoids, inflamed sinuses, croup or laryngotracheobronchitis, or an epiglottitis. These are the upper airway issues that we may encounter. Lower airway issues can be bronchiolitis, asthma, or a foreign body. A lung parenchymal issue, common issues that we encounter, pneumonia, pulmonary edema, pleural effusion, and stuff like that. So what do we need to do? We need to first identify the sign. How do we do that? So an upper airway disease will commonly present as a stridor, which is an inspiratory noise that we hear. There can be a barking cough. It can be accompanied with hoarseness, and there will be possibly suprasternal retractions in this case. Presence of these indicate towards a possible upper airway issue or an issue leading to an upper airway obstruction. A lower airway disease, wheezing. That is the sound that we hear in a lower airway disease, which is an expiratory sound. It can be accompanied with a prolonged expiration and subcostal retractions. A lung parenchyma or a lung tissue disorder will present with grunting, crepitations, decreased breath sounds, and again intercostal retractions. So presence of these three sets of features can identify which part of the respiratory system, the upper airway, the lower airway, or the parenchyma per se, is involved and the problematic area which we need to look into. So what are the initial steps or the basic steps that we need to do in any child who comes with a respiratory emergency? We need to either let the child assume a position of comfort. We need to minimize agitation. Now, what happens is we try to do a lot of things at one time. This is a child who has come to a new area, who is sick, who is afraid, who is anxious. The more we touch and play around with the child, we will only increase his agitation, and that may perhaps worsen his condition. So remember this, keep this in mind. So minimize the agitation, let him be in a position of comfort. If, however, the upper airway is obstructed and you are not sure about how the child is going to do, you may need to do the head tilt, chin lift, or the jaw thrust maneuvers to keep the child open, use an oropharyngeal or nasopharyngeal airway. Simple intervention that may help is a suction. Suction the mouth and nose, and that may help you sort a lot of the issues with the kid. Provide humidified oxygen. Start the child on oxygen, provide humidified oxygen. If you think there's an upper airway or a lower airway issue, start off with some inhaled nebulized medications as per the requirement. We'll come to that, what is needed at what point of time. Monitor the child and establish a vascular access if you can for giving the fluids and medications. Now we come to some initial disease-specific managements. So you have a child with a moderate to severe croup or a laryngotracheal bronchitis. The initial intervention should perhaps be nebulized adrenaline. The adrenaline that we get here is the L-epinephrine, and the dose 0.5 ml per kg, a maximum of 5 ml of 1:1000 L-epinephrine given as a nebulization. We may also give an IV or an oral dexamethasone, 0.6 mg per kg, maximum of 16 milligram. And if you do not have an IV access and the child is not able to take in orally or not taking orally, then you may use a single dose of nebulized budesonide of 2 mg before sending the child to a center which can perhaps do further interventions, which you may not be able to do in your OPD or in your clinic. So basic interventions for croup. Now bronchial asthma presents with exacerbation, nebulized salbutamol and ipratropium, and IV or per-oral steroids based on how the child is. You can use hydrocort, methylprednisolone, or prednisolone depending on what is available and how the severity of the disease. Angineurotic edema or an anaphylaxis or an anaphylactic situation, the most important drug over here is IM adrenaline. That is the drug which can salvage the kid immediately and promptly, and which has been shown to have maximum benefit in all studies regarding angineurotic edema and anaphylaxis. So IM adrenaline 0.01 milligram per kilogram, max dose of 0.5 mg per dose, repeated every 5 to 15 minutes should be the drug of choice in such situation. We may need to give a hydrocort, although the benefit may be doubtful, but still hydrocort is something that we still are using. Hydrocort or methylprednisolone. Methylprednisolone is perhaps the preferred steroid in this case. IV or per-oral diphenhydramine or promethazine and nebulized salbutamol would be the initial interventions for angineurotic edema. A pneumonia or a sinusitis, we can give an IV or an oral antibiotic as per requirement. And for a bronchiolitis, it's basically oxygen and fluids. So humidified oxygen and IV fluids, and then refer to a center based on the severity of the bronchiolitis. A mild bronchiolitis can go home and be under observation. A severe bronchiolitis with respiratory distress needs to be sent to a higher center where the child can be monitored, or further interventions like a CPAP or a HFNC can be provided to the child. So these are the initial disease-wise specific interventions that we may need to do in our clinics or OPDs based on the respiratory condition that we are presented with. Now, a few important practical points. Rapid breathing is always not due to a respiratory issue. Please keep that in mind. It can be due to cardiac failure, it can be due to metabolic acidosis, and it can be due to neurological disorders. We have seen it so many times. A child is breathing fast, breathing hard, but doesn't have any respiratory signs, but still is being given nebulizations and all such. Please do a blood sugar. It may be a diabetic ketoacidosis, something which we see very commonly, which is missed, and then the child ends up in the ER and the child is breathing fast, it's acidotic breathing, we do a blood sugar, it's through the roof, and this child has got a diabetic ketoacidosis. So every child who is breathing fast may not have a respiratory problem. Please keep that in mind. We need to look at cardiac, metabolic, and neurological issues also, if more so if we are unable to find any respiratory signs and symptoms when we are examining the patient. Now, when to refer a child with respiratory issues? I've already gone through this, so a recapitulation. If there's signs of respiratory distress, progressing to respiratory failure, severe cough, cyanosis, the child is too sick to feed, breathing very fast, not maintaining saturation, SATs of less than 94, please send the child to a center which can handle this kid after the initial stabilization at your center. Now, an important point, again, an intensivist perspective. A child with severe respiratory distress, impending respiratory failure may need intubation immediately at the point of first contact, but a facility to intubate may not be there. So what I would like to stress upon here is bag and mask ventilation. If the child can be bagged properly, appropriate chest rise, then you can wait for the team which can come and intubate and take the child away, a transport team equipped to handle these situations. But if you are able to bag a child properly, get adequate chest rise, you are most probably going to buy yourself enough time to ensure that a transport team reaches and takes the child away. So that's the most important thing. As far as this is concerned, advanced interventions may be required. Get a transport team, get someone who can do it. But till then, please bag the child and buy yourself some time. Now, coming to the second thing, which is the the circulatory failure part. So early recognition, why I've gone through this. Compensated shock may take hours to go into hypotensive shock, but in minutes, the child may be in a cardiac arrest post-hypotensive shock. So if we do not intervene, we lose the kid. So, please intervene as soon as possible. And that is why early recognition is important. Classification, we've gone through this: hypovolemic, distributive, cardiogenic, and obstructive. Identify and intervene appropriately. When to suspect shock: tachycardia, quiet tachypnea, cold extremities, prolonged CRT, weak peripheral and central pulses, low blood pressure, narrow white pulse pressure, decreased urine output, changes in color, sensorium. So these are the things done, and we go ahead. Again, how to stabilize a child who is in circulatory failure. So, yeah. Oxygen, the first thing that we need to do. High flow oxygen through a non-rebreathing mask, 10 to 15 liters per minute. Start this child on oxygen. Get an IV access. Give him some fluid boluses, 10 ml per kg over 20 minutes, 10 to 20 minutes. Preferably, it has to be a crystalloid. It has to be the normal saline or Ringer's lactate. Oxygen, IV access, and a fluid bolus. The three most important steps that you can do at this point of time, given that the child is presented in a shock state to you. Next, check the blood sugar, correct if needed. And after the first bolus, evaluate. Like I said, please don't walk away. You have to monitor the heart rate, the respiratory rate, the blood pressure, the saturations. Look at the extremities, look at the pulses, look at the capillary refill. Have they improved? Have they worsened? And based on that, you do the next intervention. Maybe more fluids. Repeat a second fluid bolus if there's no change in condition. And please administer the first dose of antibiotics if you're suspecting a septic shock. Collect the samples, collect a culture at least, and give the antibiotics. So these are the first few steps that we need to do if we are encountered with a circulatory insufficiency. Now, please remember that in a cardiogenic shock, fluids may be harmful. So if you have a child who on auscultation we find has a murmur and who is cold and who is pulseless and who has a big liver maybe and whose chest has creps, these are just the generic signs. Each child may not present in this way, but these are the common presentations that you may encounter when you have a child with a cardiogenic shock. A big liver with creps, with a murmur, with cold extremities and a shock state. So if you're encountered with something like this, smaller aliquots, not the 10 ml per kg bolus, but a 5 ml per kg bolus over a smaller or over a longer period of time. That is how you would go ahead with it. And any child who is in shock needs to be transferred to a PICU right away. This is the surviving sepsis algorithm. It stresses upon the fact that time is of an essence over here. So the first part is, if you see the red triangle, septic shock. If the child is already in shock, you have to do these interventions in 1 hour. What interventions? Obtain an IV access, collect blood culture, start an antibiotic, measure the lactate, administer fluid boluses, and start a vasoactive drug like Adrene, NORAD, or whatever is needed. Now, these interventions have to be done in 1 hour. So if you have a child like this who presents to your clinic, time is of an essence. You need to pick up the signs, identify the problem, and then whatever initial stabilization you can do, please do it and send the child across to the center, which can take up from there and stabilize the child further. If you're suspecting a sepsis, you have more time. You have like 3 hours to do the thing. But if the child is already in a shock state, 1 hour is what you have, and that is the golden hour. We may lose lives beyond that. So I am continuously stressing on the fact that time is of an essence for any sick child. So now is the next step. Next condition, sorry, a neurological condition. A child presents to you with seizures. What are you going to do? So the immediate supportive measures that you can do is position the child to avoid aspiration, means turn the child laterally on the side. You may need to suction out secretions, start an oxygen, check the vitals, place an IV line, check blood sugar, draw blood samples. But that is the supportive measures. What is it that is going to stop the fit? I'll divide it into 2 parts. If there is no vascular access and if there's a vascular access. So if there is no vascular access and you are unable to place an access and the child is seizing away, you can use intranasal midazolam, 0.2 mg per kg, max 10 milligram, half dose in each nostril. Buccal midazolam, 0.3 mg per kg, IM midazolam, 0.15 mg per kg, or per rectal diazepam, 0.4 mg per kg to a max of 10 milligram. These are the immediate interventions that you can do even without an IV access, which may help abort the seizure. If you have been able to place an IV access, lorazepam or midazolam are the drugs of choice in that situation, 0.1 mg per kg of each, and the seizure should be aborted. But the seizure may be back, so you may need to repeat it if needed. So with an IV access, which drugs to use, without an IV access, which drugs to use, that needs to be clear and accessible to us. Now, practical points. We give a lot of weightage to the time of the seizure. How long has the seizure been there? Because that helps tell us if the child is in status or going into status or not, because our intervention changes based on that. Now, the time that we need to take into account is from the time of onset of the seizures, not from the time when the child has come to us or presented to us. So we need to time the seizure from when the child has from when the child has started to have the seizure, not from when the child has come to us. Use short-acting anti-epileptics like midazolam and lorazepam for immediate seizure control. Repeat the doses if needed, but you may need to follow it up with a loading dose. So hence, this child also perhaps needs to be referred to a hospital where that can be done. So a child in status or recurrent seizures or who is needing repeated doses of short-acting anti-epileptics may have a depressed sensorium. He may be depressed from the seizures. He may be depressed from the medications. And repeated doses of medication may further compromise the airway, compromise the hemodynamics, may need intubation, vasoactive medication, so need to refer to an ICU again. Acute gastroenteritis, basically no dehydration, moderate dehydration to severe dehydration. The first part needs oral rehydration. The moderate dehydration can also suffice oral rehydration, but may need IV. And for severe, you need to give boluses and treat like a hypovolemic shock is all that I want to put across, and then send the child across. So acute gastroenteritis, salient important points: use probiotics and oral zinc. Use WHO recommended low osmolarity ORS. Please don't use antibiotics routinely. It is not needed. And again, a strict no to anti-secretory agents like loperamide. They are harmful for the kid and they are not going to be beneficial either. When to refer a child with gastroenteritis? If you have persistent large volume watery stools, persistent vomiting, that means the loss of fluid from the body is continuous and the rehydration rate may not be enough. So these kids may need to go to a hospital for further rehydration or IV. poor oral intake or inability to retain anything that the child is taking orally, no clinical improvement after 2 to 3 hours of oral replacement therapy or IV fluids, lethargy, drop in sensorium, dyselectrolytemia, decreased urine output. These are all signs when you need to pick up and refer the child to a higher center. So a very important aspect which I think that we need to discuss today is how to equip the practice or the OPD to handle the basic emergencies. So we need an oxygen supply, because if you have a respiratory issue, you have a cardiac issue, you have a neurogenic issue, you may need an oxygen supply to provide oxygen to the kid. So an oxygen supply is needed. You need oxygen delivery devices, simple devices, a simple face mask or nasal cannula or a non-rebreathing mask. If you need to deliver high flow oxygen, then the best bet in the clinic is a non-rebreathing mask. Connect the oxygen at a flow of 10 to 15 liters per minute, provide the child that oxygen through a non-rebreathing mask, and he does get a high flow oxygen, which will help you buy time till you can send the child across. Suction device with catheter, suctioning the oral and the nasal cavities may help a lot in taking off the secretions and opening the airway up, and helping the child get comfort. An IV cannula, very important. An IV access can help us, immensely. Resuscitation equipment, again, basic resuscitation equipment. I would request everyone to mute themselves, please. Thank you. So, resuscitation equipment, basic resuscitation equipment like a self-inflating bag and masks of multiple sizes we'll need, because a child may be of a different size. So a self-inflating bag and a mask is essential. We should be able to monitor some vitals like a heart rate, saturation, blood pressure, which would help us understand the severity of the condition.
Could we request everyone to please mute their phones? Thank you.
We may need a bit more, like medications to be kept at our disposal, and medication delivery devices to be kept at our disposal. These are all that we think is needed for the initial stabilization of the common disorders that we face in our day-to-day practices. So a nebulizing chamber, an MDI with spacer, a glucometer, IV fluids, basic fluids like crystalloids and dextrose, emergency medications like adrenaline, benzodiazepines, midazolam, and an IV or a nasal spray, both formats, bronchodilators, steroids, antihistaminics, antiepileptics, availability of a trained nurse or an office attendant, and finally, access to an ambulance service or connect with the nearest hospital with facilities to handle these emergencies, so that the child can be sent across or a team can be brought over to take the child across. Now I will come to the final part of what I want to discuss today, which is, like I said, intensive care perspective, drifting away from the core topic, but which I believe is very, very important, because we see mishaps every day on a day-to-day basis with transporting children. So how do we safely transport the kid? We get a kid in our clinic, in our OPD, and the child is sick, and this child needs to be transported. How do we do that? So I'll skip a few slides, and I'll go to one slide here. Common modes of transport in India: taxi, auto, or private car. This is how we transport sick children in India. And believe me, they are disastrous. They are not how we should be transporting children. Transporting anybody who needs a transport, who is sick and who needs to be transported to a center which can take care of that emergency. These are not the modalities that we should be using to transport. Please don't pack the child up with the family and tell them, leke jao please to so-and-so place or whatever. That is not how it should be done. Request from all of us, who we handle these cases every day, and the children are severely compromised with or even dead when they land up with us in our ER rooms. And sometimes we don't have anything to do because the child is already gone. So going back, how to safely transport a kid. Assess the child and identify the problem, as we have discussed. Start the steps to stabilize the child, again, as we have discussed. Talk to the family. This is important because the family needs to know what's going on and what is needed further. So we have to take the family into confidence that this child needs to go to a certain place, because of the availability of further management skills at that place, and which a clinic cannot provide. And the most important step next is arranging the transport for that child. How do you arrange the transport? So communicate with the nearby hospital. Whichever hospital is closest, whichever hospital with the appropriate facilities which is closest to you, that is the one you should get in touch with. Transporting long distances is perhaps not the right thing to do. So time is at an essence here. So the nearest hospital that is available to you, communicate with them, ask for the availability of a bed and possibility of a transfer in their ambulance. Ask for a pickup. They will come and pick up the kid. They will have trained people and a proper ambulance to come and pick up the kid and take it away from your hands. Preferably a doctor-to-doctor communication, because the doctor is the best person to tell and the doctor is the best person to understand. You will be able to tell best what is happening with the kid, what your assessment of the kid is, what you think is needed for the kid, so that the doctor at the other end will be prepared, will be ready, knows what he's getting into, knows what is needed, briefs the transport team appropriately, briefs the ICU and emergency appropriately. Things are ready, put in place. So the best way of communication is a doctor-to-doctor communication. Inform the relevant details. Please tell the details. Ye hai, aisa hai, this is what I think it is, this is what I think needs to be done. And take the guidance of the transport team also. You know, that the person on the other end may be able to tell you a few things. He do this, and help you with stabilizing the kid and keeping the child intact till they land up. So take help. Ask what I need to do next, and do appropriately. Sometimes it may so happen that the hospital may have a bed, but they may not be able to provide an ambulance because the ambulance is transporting someone else. Ambulance is doing something else somewhere else, may take some time to come back in. There are ambulance services available who do a good job. They have proper cardiac ambulances. They have trained people on board, and we take the help of them when our ambulance is busy somewhere. And they do a good job in transporting these kids. So you can take their help also, keep their numbers readily available with you, and ask them for a transfer. It helps. Sorry. I've already gone through this. So a trained team, which is trained in transferring sick children, with the ability to intervene if anything goes wrong during the transfer, then the person on board who is doing the transport should be able to do the appropriate intervention in the ambulance. That is of utmost importance. And therefore, the stress on the fact that take the help of ambulance services or take the help of the hospital you are referring to, get their ambulance over with trained personnel on board who can take care of any emergency that may handle that they may need to handle en route. Now, if the practice is not equipped for initial stabilization and the child needs some, then anywhere nearby, the smallest nursing home also nearby will have some basic resuscitative equipment, will have some basic medication. So transfer the child to that place, start off with the resuscitation or stabilization there, and then arrange the transport from that place. The hospital which you are referring to can pick up the child from the intermediate center where you have just sent the child over to get the initial stabilization done, if you are unable to do that at your clinic. So stress is on the stabilization and the initial resuscitation part. Either you have them with you at your clinic, the things that are needed for this initial stabilization, or you send to a place, an intermediate place where the basic things can be done, and then refer to a higher center. Because without these intervention, just packing the child up, taking the parents, abhi aap chal jao yahan pe, kyunki hum nahi kar payenge, and he needs to go, is perhaps putting the child at further risk, So transfer can be arranged from the clinic, transfer can be arranged from an intermediate place, but a transfer is important, a safe transfer is important, because this can be life-saving, and that is why I'm reinforcing it again and again and again. So with that, I'll conclude. Takeaway messages: proper assessment is very important to identify the problem and gauge the severity of the problem and start off with whatever is required right away. The PALS approach is perhaps the best way of going about it. Ensure that your practice has some basic equipment, basic emergency medications, so that you can stabilize the child there itself and then send the child across, not send the sick child across who may further deteriorate during the transfer and may land up in a state where he is not salvageable. Start the initial resuscitation and stabilization and transport safely is what I'm going to reinforce time and again. And with that, I'll conclude. Thank you very much. Sort of back to you.
Yeah. Thank you very much, Dr. Aoyon. That was really very enlightening, especially being a neurosurgeon myself. I think the last part of your talk about transporting, I think it is so critical, especially with cervical spine injuries and trauma. We open to questions. If there are any questions for Dr. Aoyon.
Hello, I can ask some questions.
Please do, sir.
Sir, I'm a GP and we have an adult pulse oximeter. So means small, infants and small children. How can we use that?
So an adult pulse ox, you are talking of the clip, right? The one which just clips on the finger.
Pocket.
Yeah. So that may be difficult to fit on neonates, but what we do is, even if you don't have it, just clip it across the palm like this. You can do this. You can put the clip like this across the fingers or across the feet. You will get some idea from it. It can still be used. It's not that you cannot use it. It is difficult. It may not be very accurate, but you can still use it and get some information.
And sir, what is low osmolality ORS, sir?
So just suffice to say that the ORS that is available in the market is now low osmolality ORS. That's what is recommended by WHO, and that's what is available in the market.
Okay, sir. And one last question is, what is the distributive shock, and what is the difference? Hypovolemic and distributive. What is the?
Okay. So briefly, hypovolemia basically is when you have lost fluids from the body, right? Either you have a severe gastroenteritis, you are vomiting, you are purging, and you are losing fluids from the system. That's one way. Or there's a trauma and there's a bleed and you have lost blood from the system.
Yes.
So any way you lose fluids from the body is hypovolemia. The volume has been lost. And the management of this is replacing what has been lost. Simple. जो निकल गया body से उसको वापस डालो. जितना निकला उतना वापस डालो. So that is the mainstay of hypovolemia. So there'll be a history. There's a loss of blood ka history. So there may be melena, there may be hemoptysis, large volume hemoptysis, there may be melena where blood has been lost, or there may be acute gastroenteritis where fluids have been lost from the body. Whatever, there's a history which will tell you that there's a volume loss. And you have to act on it by giving more and more volume as per requirement. So that is hypovolemia. Now, distributive shock is basically, as an example, it is most common example is septic shock, where the blood vessels leak and the blood from within the vessels is leaking out from the intravascular space to the extravascular space. So the blood has not left the system as a whole, but it has left the intravascular space. Hence, our circulation, the circulatory blood volume, the amount of blood which is circulating in the system has dropped because the capillaries are leaking. And then what happens? Either the blood vessels will dilate if it is a warm shock stage, or constrict if it is in a cold shock stage. But that's going beyond the brief. So just understand, in a distributive shock, the blood volume has got distributed into another compartment within the body. So from the intravascular space, it has leaked into the extravascular space in septic shock. So that is the most common example of distributive shock. Again, this case also needs fluids because the intravascular volume is depleted, and the intravascular volume is the effective volume that the body has to ensure adequate cardiac output. The blood that has leaked out is no longer participating in any helpful activity for the body. So that intravascular volume, whatever little is left, is what is there. Usko badhana hai. You have to increase that. So again, the answer over here, initial resuscitation, initial stabilization will be giving this child fluids. So the difference is there between what is hypovolemic shock and what is distributive shock, because the pathophysiology is different, but initial stabilization in both these conditions will be fluids and fluids and fluids.
Very nice, yes, sir. Thank you very much.
Do we have any more questions?
Can I ask a question?
Please do.
Hello, am I audible?
Yeah, please.
Yeah. If a patient with convulsion comes to our clinic, a child, suppose who is obese around say 40 kg, and we immediately required to give intramuscular midazolam. So as per the dose of 0.15 mg per kg, 6 ml of midazolam will be required to be given IM for a child who is obese, and we may not get an IV access immediately. So can we distribute it, say 3 ml over both the thighs?
So there is so I'll just give you one thing over here. What happened? The midazolam that's available now, it's available in 2 concentrations. There's a 1 in 1 and a 1 in 5. There's a midazolam vial and there's a midazolam ampule. The ampule has a higher strength, so it has 1 in 5. So that may be helpful when you have to give a larger dose using the ampule, not the vial, because the vial is 1 in 1 and the volume may be higher. The other thing, if you don't have an ampule, yes, you can divide and give, no problem.
Okay. One more thing that I wanted to ask, for a child who comes to a clinic with a status epilepticus, is it better to start with IV levetiracetam or IV Eptoin? And if we start with, say, IV levetiracetam, we give a dose of 20 mg per kg. Child is still convulsing, we give again a dose of 20 mg per kg. Up to what, say, for a 5-year-old child, up to what maximum dose can we give IV levetiracetam? And when should we consider Eptoin as an add-on for status?
So, very briefly, 1, you start off with Levera or Phenytoin or Phenobarb, whatever you have available, you can start off with, no problem. Okay. You want to start off with levetiracetam, no problem. 20 mg per kg loading dose, perfect, as you have said. You want to repeat, repeat, if the child is not got controlled. But my suggestion would be, do not use the same drug. If 20 mg per kg and then 40 mg per kg hasn't aborted your seizure, then going up to 60 is perhaps not going to. Change your drug. Use the second drug. So again, time is at an essence. You give Levera, you load the Levera, give an appropriate dose. Not working, go to the next. You want to give Phenobarb? Okay. Phenytoin? Okay. Valproate? Okay. Whatever you have available. But go on adding drugs. Do not wait for... You can go up to 60 mg per kg of levetiracetam safely, no problem. But if 40 hasn't aborted, 60 most probably will not. So you have to use another drug which will act in a different way. The funda over here is that use multiple drugs which act in multiple mechanisms. So it is not like you are exhausting only one mechanism of action. So use whatever mechanism of actions are available to abort the seizure, because aborting the seizure is of utmost priority over there. Keep on repeating the short-acting medicines, load with Levera, repeat with Levera if you want, but no further. Go on to the next drug and the next drug. And while you are doing that, arrange the transfer.
But sir, the main advantage of levetiracetam is that it does not cause respiratory depression, which is caused by phenytoin and phenobarbital especially. So safely, can we give levetiracetam up to 60 mg per kg before jumping to Eptoin?
Your 60 so this is what I'm trying to tell you, sir. This is what I'm trying to tell you. Keeping on loading with one drug. See, your child is seizing, right? The seizure is going to harm the brain also. The longer the child is seizing, the longer the brain is also going to take a hit. Okay?
Right.
So rather than trying to use one single drug and trying to abort it, use the other drug. Use a 15 mg per kg of loading of Phenobarb. It's not going to lead to that amount of respiratory depression. And if Dr. Pradnya is around, I think she can elaborate on this further, because she would be also part of this. But my take would be, go to the next drug. Do not stick to one drug if your child has not responded to it. It is not going to work. Your brain is going to continue to take a hit. That's why I'm stressing, arrange a transport. Call up the hospital. I need a transport. I have a child who is seizing in front of me. I'm trying to do my best to stabilize him about the seizures. Come over as quickly as possible. The child may need intubation. It was there in my slide. If you need to give multiple doses of anti-epileptics or multiple anti-epileptics or the seizures per se, you will end up in respiratory depression, respiratory failure. Your hemodynamics will go for a toss. So these things are bound to happen in a child with status. So Levera, Phenytoin, Phenobarb, Valproate, sequentially one after another, along with the short-acting benzodiazepines, arrange for a transport and send the child over as soon as possible. But to your specific question,
Yes, madam.
Hello.
Yes, madam.
What Dr. Aoyon is saying now is very much an important part of the protocol. We cannot keep on with the same drug. And if you see any of the protocols for the last 50 years, they will always say that add another drug. And one other thing about intubation and seizures, it's not only for respiratory depression. Seizures will cause a lot of metabolic derangements and a lot of stiffness of the respiratory muscles and some compromise, if not in respiration, in circulation, in the metabolic rate, everything. So intubation acts in many ways. It reduces all that very, very quickly because you take over the breathing for the child. So it's not only for respiratory depression. So yes, add the second drug, call for help. That would be the way to go for anybody in an office practice or in a small clinic.
Okay, madam. But you would also advise that 40 mg per kg is the maximum of levetiracetam that should be attended.
Yes, after that, it's your actually getting into a significant issue of diminishing returns. That drug is not going to work. And also by using two different drugs that act by two different mechanisms, you're attacking the seizures from two different sides. So it's very important to mix drugs and to add drugs.
Okay, so the next add-on should be the Eptoin 15 mg per kg, madam.
20 would be fine.
20 mg
The
per
other
kg.
one common mistake is that we add small amounts of a drug. That is not a good idea. Try and get the good level right from the beginning, right from the first dose. So don't, now we even say give 30 milligrams per kilogram of phenytoin, phenobarb, and even levera. Right from the beginning, give a high dose, rather than give small doses, because then you don't reach that level. You just maintain a low level, and that doesn't help the seizures.
Okay, so should we start with 30 mg per kg of levetiracetam?
Yes, you could easily start with 30 milligrams per kilogram.
Okay.
Just don't give it in a push, because that can cause a collapse.
Yeah. Okay. Thank you so much, madam. Thank you so much.
Excuse me, sir.
Yes, go ahead.
Hello.
Yeah, we can hear you, Dr.
Sir, is rectal diazepam suppositories will help in comparison with injectable therapy?
I did not get the question clearly.
Hello.
Sorry.
Yeah,
rectal
the question was, rather than injectable, will rectal also help fast? Or do you have to give it injectable?
Yes. If you have an IV access, please use that IV access.
Okay.
Diazepam cannot be given IM because it is quite an oily one.
No.
It can be given rectally and it can be given IV, but don't give it IM. And what happens in IM injections in these situations is there's a lot of vasoconstriction in some parts, vasodilatation in others, and you may actually land up with erratic absorption. So your drug may not act immediately, and 10 minutes later when the absorption occurs, you may see the effect. So IM should be avoided in diazepam. It can be given push comes to shove in others, but not in diazepam especially.
Thank you, ma'am. Thank you.
Great. If there are no more questions, then I think we should move on to the next talk. Thank you so much, Ayon. It was a wonderful talk and really enlightening. Thank you, madam, as well. It's my pleasure now to invite the third speaker for the day, Ms. Roshan Corey. Ms. Roshan Corey is a pediatric nutritionist, senior dietitian at the SRCC Children's Hospital. Her special interests are nutrition in pediatric neurological conditions and childhood obesity. She regularly conducts patient education and nutrition awareness programs in schools and the community. She has been a consulting dietitian for the Keto Kid project, providing ketogenic diet treatment to children with epilepsy since 2008. She has been coordinating the Pediatric Neurology rural camps, which is a social initiative to provide free medical care to the underprivileged neurology patients in rural Maharashtra since 2010. In addition, she has also done an MBA in development management. So welcome, Ms. Corey, and we are keen to listen to you talk. Thank you.
Thank you, Dr. Saurabh. So after these two intense sessions, I think we should move to a lighter topic, something I'm sure all the general physicians are bombarded with all the time by mothers and parents, over anxious, overzealous, and something the practitioners may be feeling at loss to elaborate too much. So today we are talking about diet in children, what you need to know. So basically, physicians are regarded by most individuals as the primary source of information on diet and nutrition. And this is not just a statement I'm making, but there has been research done in Australia, which has shown this result. General practitioners are in the ideal position to help people cut through the nutrition noise. Why do I say that? Because in today's time, with so many messages floating on WhatsApp and media, everybody is an expert on nutrition and diet. And the general people are just not aware as to what to trust and what to believe. There are so many nutrition quacks running around that anybody who does a 6-month course or just a 2-hour course is sending around information about nutrition, and people are getting confused about the authentic knowledge or the information. Hence, GPs are the first line who can help people to cut through this nutrition noise, to encourage them to have a healthier diet and highlight what advice to trust, most importantly. So, as a general practitioner, encouraging patients with simple but consistent messages like it is important for the child's health to eat well, or eating more fruits and vegetables will help to stay healthy when you meet the patients and their attendants, is something that will go a long way to demonstrate that their doctor places importance on the food that the patient eats. And not just a curative mode is in action where you just treat problems, but also give importance to preventing it. It is also a key to motivating improvements in the diet of your clients. To understand today we start with the main 3 macronutrients and their role in health and disease. So 3 macronutrients, protein, fat, and carbs. So carbohydrate, protein, and fats are essential for health, maintenance, growth, reproduction, immunity, and healing. And deficit or excess of any of these nutrients may compromise these processes, resulting in poor health outcomes. So proteins, in short, we know they are the help to build and protect the muscles. And they are found in meat, dairy, and some plant foods as well. Fat provides long-lasting energy and found in nuts, oil, dairy, and meat, and the fat that is extracted from it. Carbs are the quickest source of energy found in fruits, vegetables, and grains. So starting with carbohydrates, carbohydrate in the form of starches and sugars is the main energy source in the human diet. In a diet like an Indian or an Asian diet, it provides up to 50% or more of the total calorie requirement of the day. So our staple food is basically consisting of carbohydrates. The carbohydrate containing foods can be classified in several clinically relevant ways. The commonest what we see is the complex carbohydrates and the simple carbohydrates. So complex carbohydrates can be your starches, your fiber, cellulose, hemicellulose, and simple carbohydrates are basically the monosaccharides, disaccharides like your sucrose, fructose, lactose. It can also be distributed as whole carbs or the unrefined carbs versus the refined carbs. Now, this is something which people who are diet conscious talk about a lot. So the unrefined carbohydrates are basically the carbohydrates which are not processed. They are eaten in their natural forms. And this will include foods like fruits, green vegetables, roots and tubers, beans and pulses and legumes, whole grains or grains ground to a flour, corn, and certain pasta or bread which is made out of whole grain or multigrain. Besides this, we have the refined flours. Now, refined carbohydrates are basically also having a lot of refined sugars in it. So these would be foods like, and the refined products are much more processed, and this processing takes away most of the fiber, micronutrients, and the nutritional products from the original food, giving you a refined product which may be good to taste but very bad for the health. And it includes a lot of things like white pasta, white bread, colas, drinks, whole rice, white rice, and the processed breakfast cereals. So we need to understand that not all carb is bad, but it is the choice of carbohydrate that is going to affect the health of your patient. Coming next is the fiber, which is the most important part of a carbohydrate. So we say carbohydrate is bad, but fiber is the important part of the carbohydrate and which is very much essential for our general health. So dietary fiber refers to carbohydrates that resist digestion in the human small intestine. Fiber is found exclusively in plant foods, including fruits, vegetables, legumes, nuts, seeds, and whole grains. So a predominantly non-vegetarian diet would be lacking in carbohydrate, in the fiber. Also, a very processed diet would also be lacking in fibers. Fiber occurs in two states, the soluble fiber, which swells in contact with liquids, and the insoluble fiber, which does not swell. Commonly speaking, the soluble fiber is present in most vegetables and fruit, whereas the grains and legumes and pulses will have the insoluble fiber. Diets that are high in carbohydrate and fiber and low in fat and cholesterol have clinical utility in prevention and management of several diseases, including obesity, diabetes, heart diseases, and hypertension. Dietary fiber promotes satiety, and its intake is inversely associated with body weight and body fat, because more the fiber in the diet, less the portion size of the meal, because you are getting satiety faster. Higher fiber intakes also appear to have beneficial effect on the gut microbiota, and we are now increasingly knowing that gut microbiota affects a lot of diseases or unhealthy situations. Is carbohydrate really the bad boy is the question. So clinicians should be aware that patients may mistakenly blame carbohydrate for excess weight or for health problems based on the tenets of popular low carbohydrate weight loss diets. Like now, every other person you say is talking about ketogenic diet for weight loss, the Atkins diet, this diet and that diet, and the first thing to be targeted is the carbohydrate. So we need that the patients be reminded that carbohydrate is essential to human health, because the sources of carbohydrates will also provide with a lot of vitamins, minerals, and fiber, which are essential for a healthy life. Complex carbohydrates in unprocessed or minimally processed forms are staple foods in the diets of countries where chronic diseases are rarely seen. And in the areas of changing dietary patterns, where carbohydrate-rich foods become displaced by animal-derived products and highly processed foods, several chronic diseases become much more common. We have also seen a lot of carbohydrate malabsorption or intolerance. Some of the conditions I would like to mention here. We have congenital carbohydrate intolerances like sucrase and maltase deficiency, glucose galactose malabsorption, alactasia or total absence of lactase. There is fructose malabsorption, sucrase deficiency, and the most common that we face in the pediatric population is the lactose intolerance. Most of these will result in diarrhea, vomiting, or GI symptoms. And if it is a chronic condition, you will say lack of weight gain, stunting, and growth faltering. So in such situation, what you need to do is basically the carbohydrate which is not getting tolerated or is being malabsorbed needs to be removed from the diet and replaced with another substitute. Next macronutrient is the proteins. As we all know, protein supports maintenance and growth of the body tissues. The amino acids that make up proteins are used for the synthesis of nucleic acids, cell membranes, hormones, neurotransmitters, plasma proteins that serve transport functions and exert the colloid osmotic pressure needed to maintain fluid in vascular space. So basically, the major functions in the body require proteins. The protein needs are influenced by life stage. So the population that we deal with, the pediatric population, are having the higher protein requirements as their requirements are highest during the growing years. One more thing I like to emphasize here is the action of having energy adequacy, which will spare the protein. We see a lot of emphasis being given on high protein diet, give enough proteins to the child or to the patient, but we are a little skeptical when it comes to the calories. So when we are considering the protein requirements, it is important to consider the number of calories available so that the protein is not used for energy source, but rather for the functions it is supposed to do. So nitrogen sparing action is required by giving adequate quantity of calories. Illness can cause protein catabolism. So if a child is having some minor illness like cough, cold, fever, diarrhea, the protein requirement is increased. Because of low intake, the child goes into a negative nitrogen balance. But since it is a short-term problem, as soon as the child's appetite goes back to normal and he starts eating regularly, this deficit is covered and the child will come back to normal protein status. However, in the metabolically stressed patient, both inadequate and excessive protein can cause problems. So it will have to be studied properly with the parameters and the general condition and decided whether that particular patient requires a high protein diet or a moderate to low protein diet. As we all know, just to recap, the sources of protein, mostly non-vegetarian sources like eggs, meat, fish, they are considered as a high biological value protein because their absorption is best. Dairy is one of the main protein source for pediatric patients. Milk, curds, buttermilk, paneer is a common dairy product which will provide the proteins. However, there are also vegetarian sources of protein. The biological value is lower, so we need to eat in larger portions to meet the protein requirements. All kind of pulses, legumes, nuts, and oil seeds will give a good quality of protein. Soya is a very common protein, which is a pulse, which is considered to be a very high in the protein content as well as bioavailability. However, soya needs to be used only in processed form because it has protein inhibitors which get deactivated only when treated at a high temperature. So soya should always be used in a processed form and not by plain cooking like we do with other pulses. The next macronutrient we are discussing is fats. Again, this is labeled as a bad boy by general health conscious people. However, dietary fats are the least required macronutrient with only a few grams per day needed for the absorption of fat-soluble vitamins A, D, E, and K, among other functions. Foods contain combination of saturated and unsaturated fats. Substantial quantities of saturated fats are found in dairy products, eggs, meats, and tropical oils. So we do not really need to take higher or extra ghee or butter in the diet to meet this requirement, while the unsaturated fats predominate in the liquid or the vegetable oils. The latter are subdivided into monounsaturated fats and polyunsaturated fats, both of which come from vegetable sources. The essential fatty acids, omega-6 and omega-3, are also important. Some examples of food sources of omega-6 fatty acids are vegetable oils, avocados, and walnuts, while the omega-3 fatty acids can be found in nuts, seeds, and oils and fish. Saturated fats tend to raise cholesterol and triglyceride concentrations. Reducing the saturated fat intake tends to improve blood lipid concentrations. Now, this is not relevant only for the adult population, but the number of cases of obesity we have seen in children with the metabolic syndrome that is present, and this is a problem seen even in our pediatric population in large numbers. So reducing total fat is helpful for reducing body weight as well as the lipid profile. Coming to one of the most important topic is obesity. As general practitioners, you are the first people who would understand which child or which patient of yours is heading towards obesity. And if checked in time, when they are still on the verge, above the 50th centile and not yet crossed the 60th or the 80th centile, is the time when you can target these patients for help or intervention related to obesity. Obesity has a variety of effect on children. It can be emotional and behavioral with stigmatization, bullying, and low self-esteem. There could be school absences. It could be physical with physiological with high cholesterol, high blood pressure, pre-diabetes, bone and joint problems, breathing difficulties, further leading to sedentary lifestyle. There is increased risk of becoming overweight adults, risk of ill health and premature mortality in adult life. So for our obese patient, intervention is very important and it can be done or begin at your level as well. So in short, what are the interventions, prevention strategies that you talk about with your patients? Limiting unhealthy foods, most important, increasing physical activity, limiting the television time, screen time or other sick time, improving sleep and reducing stress. So these four things are like the four wheels of a vehicle which can keep the life in a healthy condition or it will get derailed. Certain tips for strategies for limiting unhealthy eating is eating regular meals and snacks. Why this is important? Because if the meals or snacks are had on time, the child is not going to feel hungry in between hours or random hours and end up eating snacks or unhealthy tidbits. Reducing the portion size. Very frequently, we see that the mothers or the caretakers tend to compare the child's portion size to their own portion size or the adult portion size and have a misunderstanding that the child is not eating enough. There is force feeding and the child ends up with overweight or obesity. Choosing calorie-free beverages. Our fridge is always stocked with cold drinks, sharbats. Winter time, it is less, but in the summers, there'll be shikanji, nimbu pani, jaljeera, and what all you can think of stocked in the refrigerator or in the house. And there is easy access for children to these beverages. It is nice if we can communicate to our parents or our patients about changing to sugar-free beverages like chas, plain nimbu pani, plain water to begin with. It would be a big save on the calorie intake of the child. Limiting intake of high-fat foods. Now, high-fat food doesn't only come from the junk food that the children tend to eat, but also from food that our Indian families tend to stock in the house, like farsan, mixtures, chakli, chiuda, puri, and an unlimited variety of Indian foods. So these are very easily accessible to the child any time of the day and contribute to a high fat intake for the day. Reducing fast food meals. Now it is becoming a trend to eat fast food meals every week or maybe every night. Either there is something like a pizza, burger, pasta, or if you come to it, even your regular vada pav, samosa, dabeli, all is fast food. These will have just empty calories, only carbs, which are simple refined carbohydrates, and fats with absolutely no other nutritional benefit. Another behavioral thing you can emphasize is not watching TV while eating. Why is this so important and why does every pediatrician harp about it? Because when the child is eating and watching TV or mobile at the same time, he is so distracted by the things that he is watching that he is hardly putting any attention to the quantity of food he is eating, the type of food he is eating, and this ends up with overeating. Limiting frequency and size of snacks, increasing the consumption of fruits and vegetables as this will provide with a lot of nutrients and it will help to give more satiety. Using smaller plates to make portions appear larger. So this is one of the tricks that I usually tell my patients, relatives, that when you're serving the food, do not use a large thali, because if you're putting a lot of things in the thali and if there is a lot of empty space, the child will perceive that the thali is empty. Rather, put it on a small plate, which looks like it is overflowing with whatever small portion you have put, and the child would get the satisfaction of eating a full thali. Consuming 3 to 4 servings of low-fat dairy products. Now, we know that our pediatric population would have dairy as a main food item. So, you can give, the child is going towards obesity, you can switch to low-fat dairy product, which is up to 3 to 4 servings per day. If it is an older child, giving around 300 ml of milk product is more than enough. This is a small slide I wanted you all to understand, so that this is a very easy way to explain to your patients in the clinic, in the limited time that you have to talk to them, how they can, how the parents can teach their children to select the food correctly. So the foods are graded as into 3 types: the red, yellow, and green. The red foods are basically all the high fat, high calorie, empty calorie junk foods. The yellow coded foods are basically with moderate calorie intake, and the green coded foods are the natural foods which are in the natural form, which are having multiple nutrients in it and lower on calories. So if the parents can grade these foods in the different top light diet, then they can give the choice of the child that these are the foods from this group you can have only once in a month or once in a week. And that way they get to eat the food, but the portion size and the frequency is restricted. Or the child can choose from whatever the green food, green coded foods are, and choose from that particular food rather than between a green and a red food. So this is like a ready reckoner for the parents to grade the food and to the child how to choose the food and how frequently to take it. Another easy way of sending this message of healthy eating is the message of 5 to 1 0. There is a rationale for this. We say 5 or more fruits and vegetables per day. Why? Because fruits and vegetable consumption controls the intake of the total calories. It gives satiety and aids in achieving and sustaining healthy weight. 2 stands for 2 hours or less of screen time, because it causes increased sedentary activity, promotes unhealthy eating practices, increased snacking behavior, interference in, because children are hooked to the screen late in the night and are not getting adequate sleep. They are waking up early, later in the morning, they are not having their breakfast, and it completely affects the whole diet pattern. 1 hour or more of physical activity. Physical activity helps to burn calories and maintain and prevent obesity. In the case of children, you cannot tell them to go for a gym or for walking or for jogging. For them, physical activity could be something like playing any games that they like, enrolling for some sports activities. If it's a vacation, during the day, 2-3 times, the children can be motivated to go up and down these stairs as many times as they like. And general running, helping in the household work, taking care of themselves. Some examples I give the mothers is like, if somebody wants a glass of water, let the child do this activity. If there is something at the door, let the child also be there to open the door along with you, so that that is the activity that will happen throughout the day. This has become important because during the pandemic, the sedentary behavior of children has become massive, and the obesity outbreak is tremendous, and it's hard time we address this topic very fast. 0 sugary drinks and more quantity of water, because sugary drinks will provide empty calories, whereas water is a low cost 0 calorie option. So a message of 5 to 1 0, you can prepare a chart like this and put it up in your as an easy reckoner for the patients who are attending the clinic. I am sure many a times you are bombarded by overzealous mothers eating of their, my doesn't eat anything, my child eats only one thing, my child is absolutely starving. So fussy eating or picky eating is a major problem with young children, and the problem doesn't happen when the child is growing older, but right at the age when foods are to be introduced, that is around 6 months of age. So these are certain tips that you could give to your young parents so that the child doesn't develop picky eating habits. First would be avoid delay in introducing foods. We see many parents choosing after the breast milk, they are choosing certain products like Parex or Cerelac, which is very gloopy and requires no efforts to eat, thereby having problem with the reflexes of chewing and swallowing. So there should be no delay in introducing lumpy foods. The child should be served child-size meals. This is something I had discussed earlier. If they need extra portions, they can ask for it. Set up regular habits for eating, such as always putting the child in their high chair or eating at the same table with the family. Most of the times we see, whenever we see a recall, we see that the eating habit is such where the child is roaming around the house with the mother or the grandparent roaming around with the plate behind the child. And for the child, this is like a play activity and not eating. So there is no constructive way of eating the food. Child does understand that food is his requirement and not something that is the problem of the caretaker. Do not limit the child's food variety to only those foods that the parents prefer. We see a lot of cases where the parents themselves are not eating a lot of foods and the child follows them. So telling the parents to be good role models goes a long way in avoiding the child becoming a fussy eater. Encourage self-feeding and exploration of food from early age. We see a lot of patients coming with a 5-year-old, a 7-year-old child still being fed by the parents or the caretakers. So the child should be encouraged to eat on their own at the appropriate age. Some parents are very upset that the child becomes too messy, the food is wasted. So we need to counsel them that that is all part and parcel of child learning. So you have to allow the child to feed himself. Very important, do not use things like chocolates, lollies, biscuits, milk, or dessert as bribes. We see that many a times if the child is behavior is rewarded with a food item or a sweet meal, and this forms a very bad precedent for the child. Offer range of colorful foods on the plate and allow the child to pick and choose what they will eat from there. Many a times mothers complain that, or many mothers complain that the child is not eating vegetables or fruits at all. So the option would be to give an assorted plate where the child makes the choice of what fruit or vegetable he wants to eat at that particular time, rather than giving just one food which he is refusing to eat. Do not be resentful when they refuse to eat. Do not threaten, nag, or yell at the child regarding eating, because then it becomes a very difficult time. Meal times become very stressful. The child does not like to eat because the whole environment is so stressful and not at all happy. Assess your child's food intake over the week rather than daily is one more advice I give to mothers, because the child's food intake may change on daily basis, but you have to assess it over the period of time to understand whether it is adequate or less. I know that most of the common conditions that children come to you all will be things like fever, diarrhea, vomiting, dehydration, abdominal pain. Most of all, which will affect the child's food intake. And the minute the food intake goes down, the parents are in a panic mode. So they are worried about the fever, but they are more worried that the child has stopped eating. So at this, counsel the parents saying that we can take whatever they are comfortable with and give them a choice of the texture or the consistency of the feed that the child is most comfortable with. It can be something like clear liquids, which can also act as ORS. And these includes foods like coconut water, rice kanji, dal water, clear strained juices, clear soups, nimbu pani, api, soup. Or if the child is feeling better, you can give full liquids like juices, which are unstrained, cream soups, milk, fruity, milkshakes, which are strained, buttermilk, lassi, cream soups. Once the child is feeling better and is okay to take soft diet, things like upma, khichdi, shira, halwa, kheer, porridge, soft rice with dal, soft boiled eggs, mashed potatoes, mashed vegetables is something that the mothers can offer the child. And then slowly the child needs to progress to a full diet. So it is important that you emphasize to the mother that as the child progresses to feel that better, they go back to a normal healthy diet, because many a times we see that the child is being pampered or compensated for being sick by being offered whatever the child likes to eat, and most of the time it is either junk food or a low nutrition food. One more thing that you people, doctors would be bombarded would be to get a prescription for a nutritional supplement. Now it is something that is a little controversial, whether the child should be prescribed a nutrition supplement or not. A child will need a nutrition supplement if his food intake is not adequate due to some genuine reason. If the child is preferring unhealthy foods and that is causing weakness or problem in his health, then nutrition supplement shouldn't be the first choice. The parent should be counseled duly to change the food habits of the child, to change the construction of the meals. For example, many families we see that the dinner is usually composed of a snack item. They usually do not have a full meal consisting of grains, protein foods, vegetables as a meal. Usually it is some junk food like pizza, pasta, bhel, just simple poha, or just an idli with chutney or a dosa with chutney. Now, when a meal is composed like that, they are missing out on the main components of the balanced diet. So the first step would be to change the diet of the child and the family as a whole. But if you feel that your child requires some extra nutrients, you can always go in for a supplement, but you need to understand the different supplements that are available in the market. The standard polymeric feeds are something that would be the first thing you would choose. These are feeds which are based on cow's milk protein with fiber in it, which have energy and nutrient content adapted to the requirement for age, are appropriate for enteral feeding as well as oral feeding. For most infants, children, and adolescents, these polymeric feeds can be served as a sole source of nutrition for very sick babies, like the neonates or infants, like products like Nanpro, Lactogen can be given. Or for older kids, Pediasure, Pediagold, Ensure, Research, Opti, Presvin. I'm just giving a few names. I'm not endorsing any products because these are the products that you can understand which fall in which category of the type of formulations. We also have something called low molecular feeds or the oligopeptide feeds based on protein hydrolysates and the elemental feeds based on the amino acids. These are used in selected patients, for example, those with food intolerances or impaired intestinal absorption and or digestion. Example, products like Peppermint Junior, Pediagold Plus, Pentasure Pritipat, and are mostly utilized for hospitalized children with increased requirements and very low intake orally. There are also disease-specific enteral formulations available in the market and may be beneficial in certain circumstances. However, claims of benefit should be evaluated critically. Also, there are very few products which are suited for the pediatric population. The ones available for the adult population are Ensure DM, Pentasure Renal, NovaSource, Nutriab. So you have to be very cautious when you are prescribing a Pediasure or a Pediagold to a patient. Emphasize first on the dietary improvement and then, if required, prescribe a formula. These are very easily available over the counter, but I think you should sensitize your patient attendants that this shouldn't be the first choice for improving the nutrition. Nowadays, a lot of things are being said about the use of functional foods. Now, what are functional foods? Functional foods for children are foods which support health and well-being in kids, protect against diseases, foods that provide naturally occurring vitamins and minerals for optimal health with an abundance of absorbable nutrients with no potentially toxic ingredients. Basically, functional foods are normal foods. The example of functional foods are fruits, example berries, kiwi, pears, peaches, apples, oranges, bananas. Vegetables like broccoli, cauliflower, spinach, zucchini. Nuts like almonds, cashew nuts. pistachios, seeds like chia, flax seeds, pumpkin seeds, legumes and pulses, whole grains, seafoods like salmon, sardines, anchovies, mackerel, herbs and spices like turmeric, cinnamon, ginger, cayenne pepper, beverages like coffee, green tea, black tea. Now, these foods can be easily incorporated in the diet by giving a balanced diet. You need not necessarily emphasize about giving one particular food. There is no particular food which will give all the nutrients in one dose. So you need a variety in the diet to make the diet a balanced diet, and functional food is part of a balanced diet. So this is my last slide. Coming to the crux of the matter, how do you make your child's patient's diet healthy? By making it a balanced diet. It is very easy to get a balanced diet by understanding the 5 food groups. The first being the largest portion in the diet, grains. Now here you see a variety of processed or unrefined grains. These can be changed over with things like rotis, which are made out of wheat flour, dalia, suji, grains and millets like ragi, jowar, bajra, and a number of other things which are used commonly in the Indian kitchen. The second group is vegetables and fruits. These are further divided into the protective fruits and vegetables and the other fruits and vegetables. The protective fruits and vegetables are all those vegetables which have color. Either they are green, red, orange, purple. So these have a lot of vitamins and antioxidants. The other vegetables and fruits are the ones which are white in color and are having basically the roots and tubers falling in this category. The third group, the fourth group is the protein-rich foods. These are milk and milk products and non-vegetarian foods, as well as things like pulses, nuts and oil seeds and soya bean. And the last but not the least is the group of fats, oils, salt and sugar. And these needs to be used in the least quantity because excess intake of this is going to cause problems. And now if we see the kind of diet we are using is like an inverted pyramid. So the fat and the sugar content in the diet is more, meat and the processed foods are higher, fruits are lesser, and the carb containing foods are minimal. So this is the right approach to getting a balanced diet, and it's easy for you to explain to your patients in the clinic practice that how is it possible to get a balanced meal, and including all these vegetables in the 3 main meals, that's the breakfast, lunch and dinner, will help to get a balanced diet and meet the nutritional requirements of the child without any artificial supplements. Thank you.
Thank you very much, Roshan. It is indeed quite enlightening, common things, but things that need to be paid attention to. Are there any questions for Roshan? Any? Well, so if there are...
good afternoon.
Yeah, please. Yeah.
Good afternoon, sir. Good afternoon, madam. It was an excellent lecture. I want to ask you how much gram per kilogram protein should be allowed in children's?
The rule of thumb is 1 gram per kg body weight, but as I said, it will differ from the age to age. So anywhere from 1 to 1.5 gram is the rule that we use.
Okay.
If there are no more questions, then I think we will close this session. I'm
Can
really
I ask
thankful.
can I ask a question?
Please.
Madam, those who are obese in the pediatric age group, they remain obese throughout their life. Is it possible? Or is it right?
No, sir, it is not right, because at SRCC, we have an obesity clinic, which is a group of doctors together who work towards this problem of obesity. So we work on children, and we have seen that when we approach obesity in children, it is with a different point of view. So as children are growing in height till a certain age, we can arrest their weight gain at an early stage, and we inculcate the principles of good diet, exercise, screen time being reduced, and proper sleep. And we have seen the children get transformed and maintain the weight as they grow older, because the aim is to bring about lifestyle change. So if this lifestyle change is carried on further in life also, there is no reason for the child to remain obese all the time. Since we are removing the problem areas, once the problem area is removed and the child's lifestyle is transformed, he will become a healthy individual.
Madam, can I ask one question?
Yes, please.
Madam, the other day I was watching the webinar. The cardiologist told that folic acid and vitamin D3 it retards the atherosclerosis. So in adults, what can you suggest? Daily dose of vitamin and vitamin D3, vitamin B complex, folic acid, and what should be the dosage and duration of the?
See, vitamin D is usually prescribed depending on the symptoms and the blood parameters. So if you have symptoms which suggest it is a vitamin D deficiency, you would definitely follow the protocol which is laid down by the board, and it will be whatever is prescribed by your doctor. Coming to vitamins, you cannot randomly keep on taking vitamins, especially the fat-soluble vitamins like vitamin A, D, E, and K. It has to be followed as per the protocol suggested by the doctor. The water-soluble vitamins like the B complex vitamins, vitamin C, can be taken if you feel that you are really having a lower intake of it, in spite of eating a balanced diet. So suppose you are in a stressed health and your requirements are higher, you have had phases of illnesses frequently, you need to improve your immunity, then you would take a multivitamin tablet or vitamin C on a long-term basis. But I don't think more than 3 months at a stretch. However, this all should be done in discussion with your physician.
Madam, is there any role of hormone ghrelin and leptin in the causation of obesity?
Absolutely. This is like a completely different part of obesity, and that's why here at SRCC we have the endocrinologists who are part of the obesity. So these are the things which play a major role in some of the types of obesity and cannot be completely changed only with diet and lifestyle modification. There'll be interventions required from the endocrinologist side in terms of medicine and other investigations. So yeah, this is definitely has a role to play in obesity, but may not
in
be
addition
true to
to
all
vitamin D, are
obesity
there
cases.
really any dietary sources for vitamin D?
Dietary sources, very few. The availability of sunlight is one of the biggest source of converting vitamin D, and the other being milk products in very, very minimal quantity. But we cannot see that there is a very good source of vitamin D in diet. Very minimal.
Vitamin E, madam? Vitamin E, any dietary source?
Vitamin E is available in vegetable oils and from all kinds of sprouted legumes and pulses.
And madam, soybean, when the soybean chunks are available in the market, which are very easy to prepare. So is it recommended to be given, can you give it to the children if they can, if they
Yes,
like it?
so soybean chunks are processed soya grains. So it can safely be used like any other pulses. It can be used in the diet in different forms, in the form of a vegetable, in the form of a stuffing in a paratha, or as cutlets in different forms. It can safely be given to kids.
Okay. And madam, whey protein, which has come up, new thing is whey protein. It's quite hyped up. Is it really so, or it's just a marketing gimmick? Whey protein, whey protein. And
see, whey protein is basically derived from the milk. It is a good quality protein, but the whey products that are available in the market are in different forms. Like normally the whey that you would, I think you are talking about, is something that gym instructors would recommend to children, or young adults, or people who are going to gym. Now these are concentrated in the term that one scoop would give you something like 25 to 45 grams of proteins at one go. And I think you yourself would agree that it is not healthy to have so much of protein at one go, as it is going to affect a lot of your organs, including the kidneys, right? Yes. So the answer is no, it is not a very right thing to go for use of whey protein blindly. Many of the protein supplements that you get and are used for sick children are also whey based, and we recommend to use that, but the dosage and the type is highly monitored.
Okay. Thank you very much. Thank you.
One more question. What is the vitamin D and calcium level in a ghee, Indian butter? Exact 100 gram wise.
Calcium in ghee not available. Ghee does not have calcium. Vitamin D maybe. Vitamin D, I am not sure it is there in the ghee. Vitamin A is there if it is during the summer season, because the cows are eating a lot of green grass, and from there the vitamin A is coming to the ghee. But vitamin D is not available in the ghee. Vitamin D is fortified in dalda, which is a trans fat and strictly not recommended because it is a very bad kind of a fat for atherosclerosis.
Madam, one more question. What is the difference between yogurt and curd, dahi? Is there any difference?
Not really. I think as the other our doctor was saying, that it's mostly a marketing. Yogurt is what the Western population would say, and curd is what we call the regular curd, which we make at home. In the Western population or other countries, it is not very common to set curds at home. So you get it in the ready-made in the market, and mostly in our Indian context, yogurt is considered as a flavored curd. So whatever the flavored products that you get, which has sugar in it, fruit pulp in it, are basically considered as yogurt. It basically means some the curds which has been changed and made into a much more prettier form.
Process is some different, I think, for making yogurt and the ghee.
When we make curd at home, we use the original, the previous day's curd and add it. The culture that comes is from the curd. When yogurt is made, it is commercially made, and the enzymes and the bacteria are added are in a different manner. So yes, the production is completely different.
Okay. Yeah. Thank you.
We will add the microorganisms. We do not add the microorganism. We just add the culture. You understand?
We
so
use
it's a different process of preparation.
We use lactobacillus.
Right. Which comes from the previous batch of curds.
Yeah.
And it is not monitored and it is not controlled.
Correct.
Madam, what is your opinion regarding this ghee? It is said that it contains omega-3, heart-healthy omega-3 fatty acids. How much is the daily allowance for ghee, pure ghee?
When we are recommending the use of ghee, we say the general for a child, the ghee total oil allowance should be anywhere from 15 to 20 gram per day maximum. That is 3 to 4 teaspoons of oil or fats per day. When we recommend, we say that 1 teaspoon of it can be ghee or butter, which is a saturated fat, and the rest 3 should be a vegetable oil. It can be any of the vegetable oils like groundnut oil, rice bran oil, olive oil. So the majority of the fats should come from the vegetable source, and only 1/4 or 1/3 should come from ghee, because it's a saturated fat and excess use can cause increase in the cholesterol and the lipid profiles.
Thank you. One final question, ma'am. It is the caloric restrictions to reduce the weight, or it is a high protein, no fat diet that is much more important than?
So this is a very common debate that is going on now. What with the ketogenic diet and the intermediate fasting and everything. Ultimately, all these diets work with the principle of calorie reduction.
Yes.
And giving satiety to the person. So the same can be achieved by a balanced diet, which a qualified dietitian would suggest for you, or you can get it from a fat diet like intermittent fasting or a ketogenic diet, but then there will be repercussions coming out of it in terms of malnutrition in form of multivitamin deficiencies, acidity, constipation, or a deranged lipid profile. and increased uric acid levels. So it's up to you to judge as to what is the best option. The principle still remains the same, calorie reduction.
Yes,
So do it the healthier way, or you do a shortcut and then take a long route to the hospital.
Yes. Thank you. Thank you so much, ma'am. An excellent presentation.
Thank you.
Great. That was really a very nice discussion. Thank you. Thank you so much. So with this, I will come to the close of this webinar. It was indeed encouraging to see such a good attendance. And I would again take this opportunity to thank all the three speakers, Dr. Pradnya Gadgil, Dr. Aoyon, Sengupta, and Mr. Roshan Corey. Thank you for sharing your thoughts with us. And until the next webinar, each and all of you take care of yourselves and see you soon. Thank you.
Thank you, sir.